erstwhile casualty. Casualty, everything was casual. So now it's shifted that nomenclature has changed to EM. EM has to cater to those students as well. That's a shop window for them. Remember, that's the first posting many of them are having in the hospital side. A very, very important responsibility with the Department of EM to train even the undergraduates. Number two, the interns. It's extremely important that the Department of Emergency Medicine takes over this particular responsibility. For age-old, this has been taken by Department of Community Medicine. The administrative aspects can... Any other questions? One more question.
Very well covered by Dr. And any questions?
There's one more person.
I think we are running behind the schedule, so
just give me 1 minute.
Regarding
Regarding your query, I am Dr. Krishan Kumar. I am looking after the National Program for Prevention and Management of Trauma and Burns Injury in Ministry of Health and Family Welfare, Government of India. So, regarding your query, now you will be having so many ads from the different medical colleges, so you can apply there and you can be a faculty in any of the medical colleges, because now as per the NMC, this is a mandatory department which need to be created in every medical college, so there will be no dearth of the vacancies. So just wait for some time, you will be wanted everywhere in this country, so there is not a problem in this regard. Yeah, government medical colleges, because in each and every medical college, once Department of Emergency Medicine is an essential department to get recognized as a teaching institution, so they will be requiring teachers all over the country, so you will be having lot of opportunities. And Siddharth, regarding your, are you happy with the, you and the professor who took the Dr. Sagar are reminded that it's a surgical specialty. But I don't think that we are in a position at this moment of the time. How many surgeons will be ready to take this as their career? Very less. Because if you see the curriculum of this emergency medical teaching syllabus or curriculum, whatever you say, are you satisfied with that? With this curriculum, will a person who has done 3 years of post-graduation in surgery will like to come in this specialty?
See, first of all of you should need those competencies, the core competencies which have been identified in the 2014 document. If they are implemented in true spirits, I think we have done justice to the program. The identification of a specialty as a medicine specialty or a surgical specialty does not depend on which faculty will be coming to teach. It depends on the proportion of the competencies which are there in the curriculum. So if you see the competencies which have been identified in the white paper, 2014 paper, 60 to 65% of the competencies are from surgery and allied disciplines. Hence, it qualifies to become a surgical specialty.
Actually, the whole confusion comes because when you call it emergency medicine, and medicine is medicine. So why don't you call it emergency medical care? So that then the issue closes. Emergency medical care rather than, then it is surgical, it is orthopedics, it is medical. So
there is always
emergency medical care.
Yeah, sir, so as in the morning I have said that we need to sit together. Rather than saying that I am better and they are better, it's not the question. It's the beginning. You have done hard work since last 14 years. I can see that. And I can see that frustration in your lectures also, but don't be disappointed.
There is no frustration.
I can see that because...
There is no frustration, there is passion.
No, it's not...
because if we get frustrated, we can't move ahead. I'm sorry, I beg to differ with that word.
I think we are diverting from the main issue.
So I will sir, please request that we can sit together and discuss over it.
Thank you.
And at the end, I will say that I am also surgeon. And ultimately, we will have to develop a mindset of an emergency medicine branch, and we have to come out from our surgical or medicine or that label, and we have to develop it as an emergency medicine, as a subject on its own. And we have to stop thinking that we are surgeon or we are physician and all the things. And when we develop it as an emergency medicine specialty, then only it will develop in a true sense. That is what my personal thinking. I'm not thinking on behalf of, talking on behalf of NMC right now. And so with that thing, I think we will end this talk of Dr. And now we'll go to the next talk of Dr. Nurullah from Vijayawada, and he will talk on the National Emergency Life Support Training. May I invite Dr. Nurullah Kas?
Thank you, sir. Now we will have, now we invite Dr. Vijay Vasantra Oza to give the certificate and memento to Dr. Siddharth Dubashi. Thank you, everyone. Now we will have an online session by Dr. Vanessa Naidu on global perspectives of integrated emergency and trauma care. Dr. Naidu is an emergency physician currently working as WHO Technical Officer in emergency care with Clinical Services Systems Unit at WHO headquarters. Thank you.
Hi there. Are you ready for me to go ahead?
Hello, madam, we can hear you.
Can you hear me?
Yes, you are audible, ma'am.
Okay, thank you. I'm Dr. Vanessa Naidu from the WHO. I am really grateful to the organizers for allowing me to speak right now. I know it's not my time yet, but I'm only available for a few minutes now because I have another engagement. I'm speaking on behalf of Professor Lee Wallace. And I'm going to talk to you a little bit about our work around emergency critical care and trauma. So if I can just share my screen. Is that coming through? Hello?
Madam, we are on it.
Are you able to see my screen?
Not it, madam. Just a minute. Yes, ma'am. Okay. Okay, madam. You can proceed now.
Okay, so we're going to talk about a global perspective on integrated emergency and trauma care. Like I said, I'm speaking to you from Cape Town today. I work in Geneva, but I was trained and I lived in South Africa before that. Our unit is Integrated Health System, so that is the department we work under. It is a day-to-day WHO service unit, so not part of the emergency unit. And we fall under universal health coverage over the life course. And integrated health services deals with the clinical and the systems components of healthcare, so infection prevention and control, patient safety, quality of care, health system performance assessment, and traditional complementary medicine, and the unit from which Professor Wallace and I come, clinical services and systems unit, which is involved in designing clinical services and systems for primary, emergency, critical, and operative care. So this is the structure of our unit. So to say that we focus primarily on integration of primary care, critical care, and operative care. So not in a siloed approach, but a more integrated view of the patient's progression across the platform. And there are certain cross-cutting elements that we work on, such as trauma care, sepsis, and hospitals work. So more especially in the COVID-19 pandemic, it came out how much more we need to concentrate on hospitals rather than just a purely primary healthcare focused approach. We also look at models of care and packages of care ranging from what should be available in terms of services and equipment and staffing needs from district level all the way to advanced and tertiary level, and pathways of care. So how does the patient get from the scene of an accident, for example, to a referral hospital? What is that system that is in place? Our work is defined by certain resolutions that are defined by the World Health Assembly. So the first major one was in 2007. So that was for strengthening emergency care systems. And the other main one that we work on is emergency care systems for universal health coverage, which was 72.16. And every year there is a new discussion about new resolutions that are put forward from countries that are voted on. And the one for this year that has come up is for integrated emergency, critical, and operative care for universal health coverage and protection from health emergencies. So this will come to the World Health Assembly in May, and member states will come together and their representatives will vote on whether or not we should go forward with this and design a work program for us based on this. So our products are based around toolkits. So I will speak a little bit about learning programs and clinical toolkits. And we work across from primary care, as I said, all the way through to mass casualty management and surge response. So there is a little bit of overlap between the work we do and the WHO emergency response systems. I'm sorry, the slide is a little bit busy, but this is our integrated clinical care learning programs and toolkits. So as I said, on the one hand, we have educational programs, so basically short courses that are designed either for face-to-face or online use. And then we have clinical tools, which are either decision support tools or clinical process guidance that can be used in the real-time setting. So I'll talk a little bit about those as we go. So the emergency care toolkit, which is one of the specific focuses, is the most developed of all the toolkits and has been being developed over years. It composes the pre-hospital system, our surge capacity, standards for quality improvement in data, some training, triage, and then some governance and legislative components. The basis of the emergency care toolkit is the emergency care framework. And it may seem like a simple infographic, but it contains all the components of a functional emergency care system, including scene care, so transport at the scene, treatment at the scene, so whether provided by bystanders or pre-hospital providers. Can somebody arrive at a patient? Is there a number to call? Will somebody be dispatched to help? And in that case, how will the patient then be transported to hospital? Is there care during transport? We say that an ambulance is defined by having two people. There has to be somebody who's providing treatment and a driver who's driving to the hospital and not merely just a taxi service. And then facility-based care, so the main components being some sort of handover between transport and facility-based care with triage. It is member states ask us to come in and have a look at how their emergency care systems are working and functioning. And we send out then a survey that has a consensus-based survey. It covers areas such as system governance and financing, data use for quality improvement, pre-hospital care, facility-based care, and mass casualty or emergency preparedness. And respondents do that survey, and then we go into the country and we have a 2 or 3 day workshop where we discuss this with stakeholders and decide on priority actions for the country and the emergency care system. So many of the tools that we designed are based on answers that come out of these assessments and what countries ask based on that. So it has been a very impactful exercise, and we are still ongoing and expanding to other areas. So moving on a little bit to the courses that we offer. As part of the toolkit, we have the basic emergency care course, and this is our flagship course that has been around for more than 5 years and has been done in multiple countries across the world through different organizations. It's a free open access course that's available online, and it teaches a syndromic approach to emergency care following ABCD approach for trauma, difficulty breathing, shock, and altered mental status. It is available as a 5-day face-to-face course that has to be done by specifically trained master trainers, and is in the process of being converted to an online course in the WHO Academy. So it will be a hybrid course in which we have online modules that can be completed prior to a practical learning lab. So people will do the online modules at their own pace. And one of the reasons we've done that is because it's difficult to get clinicians off the floor in order to come and do a 5-day course, and that's one of the complaints that we get. So we've tried to go for this hybrid model where people can do the online component and then come in for a 1 or 2 day portable learning lab. And we're doing this in conjunction with the WHO Academy on their digital learning platform. Just some pictures of a BEC course in the face-to-face format. It's been done in multiple countries through, especially in Africa, through the African Federation of Emergency Medicine. There is a credentialing process that is run through IFEM, so the International Federation of Emergency Medicine, who make sure that people who are trained in the BEC course are then selected to become trainers. Those trainers undergo a training of trainers course to become provisional trainers, and then once they've trained under the supervision of a master trainer, they become master trainers themselves. And the point of that is that the course can then cascade without direct WHO involvement, and it can be taken over by the health system and the ministry, and it can go down to facility level as needed. So it may be then expanded. If you can't do a 5-day course in your facility, then you divide it into modules, and you may do it over a month or 3 months as you wish. Similarly, we have a mass casualty management program, learning program, also available as an in-person course for 2-3 days, or an online version that will be released soon. This is just a clip from the online version. Just to give you an idea of an overview, so I've spoken specifically about the basic emergency course and the mass casualty management, but this is the continuum and the platform of our courses. Most of them are based around basic emergency care, but we start with community first aid, so for lay people, basic ambulance provider course, which is under development at the moment, that will be for pre-hospital staff. We have a primary care component, which is a little bit separate, and then critical care, which is also underway, and part of that forms sepsis care and trauma care. So just last week, we had the first focus group for the advanced procedures course, which is part of the trauma care course. And then we have a large operative care module that is coming out, which will also be an operative care learning program and a toolkit for that. So just talking again of pre-hospital tools, like I said, there's the community first aid responder course, and then there's a basic ambulance provider, and then there's all the tools that go with that. So there is also a pre-hospital assessment tool, medication and equipment guidance, and SOPs for clinical treatment on the scene. So other tools that we have in our toolkit, so we talked about basic emergency care. There's the triage tool. We have resuscitation area designation, checklist, and standardized clinical forms. And these very simple, cost-effective interventions cover basically all of emergency care that we deal with. The triage tool is a consensus-based document. It's a 3-color triage tool that was developed between ICRC, MSF, and WHO, with multiple rounds of consensus meetings from triage experts around the world. And it has been implemented in multiple countries. The picture that you see is from Papua New Guinea, where they did a validation study and showing that also the triage doesn't only impact prioritizing your acute patients, but also affects the way your system works and the way your patient flow is run. An example from Uganda, just how simple interventions can improve systems. So part of the resuscitation area designation is emergency trolley checklists and guidance for what should be on there and how you should manage that. You see the medical emergency checklist hanging on there, triage, and then just emphasizing the fact that you do not need a huge amount of resources in order to provide acute care. Just designating a place with a red sticker on the wall, knowing that this is where your most sick patients are and this is where you need your equipment is probably enough in most cases, and it has had an impact. So that brings me to the Global Emergency and Trauma Care Initiative, which was run initially under the AO Foundation. It was a funded project. This part was done in Uganda and Ethiopia in the pre-COVID era. And we have unpublished data that shows that compared to pre-implementation data, implementation of simple elements like the BEC course, triage checklist, and resuscitation area designation had up to a 50% decrease in mortality in the countries that it was done in. And we can talk a little bit more about that if we need to. So when we talk, mainly it was done for sentinel conditions. So we look at road traffic accidents and injury, asthma, pneumonia, diarrhea, postpartum hemorrhage, and diabetic ketoacidosis. And this is done at selected facilities. So we've now done it in Sudan, in Zambia, in Nepal, and we are now moving into a patient satisfaction and qualitative component, which will be done in Timor-Leste and in Jordan in the next few months. Just a picture of where we are working. Let me go a little bit quickly. And then we have our clinical registry. So this was based initially around the ERTEC, which you may be familiar with, was the trauma care registry that has now been expanded. And last year we had a meeting in Norway at Utstein to decide on the variables for the emergency care module of the toolkit of the clinical registry. And this is a DHIS2 based system where it's often linked to a standardized clinical form where the variables and indicators that need to be collected are extracted off a form and entered into the system. It then allows you to create certain data visualizations that may be either based at the facility, or if you have access to aggregate at a higher level than that, so either subnational or national level, depending on their access. The data belongs entirely to the country and not to WHO, and we do not use it or publish it in any way unless we are asked to, or there is a specific project that we have consent from the country for. The registry has been used in multiple countries for quality improvement. So using audit filters, you can, for example, look at a patient who was hypoxic and see whether they have received oxygen. So that you are able to pull that out of the registry data automatically using the system. And then you can go back and do a folder check to have a look at exactly what happened to that patient. And that has been done in multiple countries. And that's all from me. Any questions? Or?
Thank you, madam. The topic is open for discussion. No discussion. Now we move on to the next topic. Thank you, madam. Our next talk will be by Dr. Nurullah Kas, Associate Professor, Emergency Medicine, Government Medical College, Vijayawada, to talk on National Emergency Life Support Training.
Respected dignitaries on the dais, off the dais, the organizers, the senior professors, senior faculty, junior faculty, and all the organizers. A very good morning to all. We have welcomed this decade with happy moments. Then that happy moments didn't last for long. Within a month, we suffered from a global emergency called COVID. Okay. During the COVID, not only the India, all the countries were under lockdown. Okay. Okay. Yeah. When there is a global emergency, COVID, all the countries were under lockdown, and India too. Next, what to do? Nobody knows. The healthcare professionals were busy in treating the patients. The police personnel and the municipality workers, altogether, they became a COVID warriors, and effectively we have managed this COVID. Okay. And the general public is very confused about what is going on. There is a global emergency. At the same time, there is a recession in all the countries. And the general public, because of the loss of jobs, loss of wages, they are in full confusion. But our visionary leaders, with great minds, they have developed a concept called National Emergency Life Support. Other than the regular work, they have put their great minds to develop a course which is very helpful and which is very needed to this country at this moment. I thank Dr. Rajesh Malhotra Garu from AIMS, who has taken a lot of pain to develop this course. Health professionals in our country, they are dependent on the foreign certifications like ATLS, ACLS, PALS, NALS, BLS, etc., etc. They are like short duration course, of course, well structured, but short duration course, 3 days is not enough to get trained. It needs more, and it needs a regular revisions also. And moreover, it is very costly. You all know like ACLS, nearly 8,000 to 10,000, ATLS, nearly 30,000. It's not affordable by so many people. So the government of India come up with a great initiative to have a Make in India concept toolkit. Okay. That is nothing but a national emergency life support, which is very mandatory to all the healthcare professionals working in the emergency department. It's not only the doctors, it's for nurses, it's for paramedics, it's for the transporting personnel involved in dealing with the emergency cases. And it should be extended to the general public too. We have to create awareness regarding the emergencies. Then only the public also will understand and it will give more support. I'll give you an example. I had a busy ED. One case had a cardiac arrest. I am working in a government sector. There are a lot of cases will be there in the ED. Then one cardiac arrest was there. So immediately I started resuscitating, and of course effectively we have managed that case. Later one PG came to me and asked, "Sir, what you have done is excellent, but regularly we are unable to do it." Then I said, "See the response from the other patients. Till that time they were making lot of sounds. You are not taking care of my patient. You are not giving proper care. We have to admit, you are not given the purchase, the papers, all these things." But when I started resuscitating that patient, everyone is calm. Everyone is quiet. Because they are observing what is happening in the thing. And in the moment we have resuscitated the patient regained his ROAC, return of spontaneous circulation. Then everyone is happy, then everything is streamlined. Okay. So we have to teach the general public too. So pre-hospital emergency services in the institutions, in the emergency department and trauma care delivery are being continuously strengthened by the National Health Mission with support from the Government of India Medical and Health Services. It is supported by your Ayushman Bharat also. And emergency medical services extends the care at the scene level. And it goes to the hospital, to the main center, through the transporting system also. Okay, it will start in the field, then it will reach the hospital. Till that time, en route also they will give the proper care. Delivery of the time-sensitive healthcare services will prevent so many disasters, so many deaths, and so many deaths. And that is realized when you lose something, like when you are unable to do unable to get the proper care, will get realized. That's why our emergency medical care personnel are very important, who are effective in saving so many lives. And it forms the important component in taking care of the mass casualties. Like you have road traffic accidents, like bus accidents, train accidents, or a drowning, or fire accidents, like that. A study was conducted by ICMR in 2017, which says nearly 9.7 million deaths occurred, and 486 million they have daily disability-adjusted life years. It is a huge burden on the nation. Like we are losing so many persons, and we are like unable to save some patients, and we are unable to, we are making somebody into a daily adjusted life. That means a permanent damage. Maybe it is a loss of limb or some vegetative state. The top killers among them is ischemic heart disease, perinatal conditions, chronic respiratory diseases, diarrhea, respiratory infections, cancer, strokes, and road traffic accidents. Road traffic accidents are major because it involves the youngsters, youth of the India. Okay, if you are able to prevent these road traffic accidents or able to provide the care after accident, then you can save young people in the country. And another study on the spectrum of pediatric and adult emergency case load across the India revealed 9 to 24 cases are of road traffic accidents. It's a major part. And it involves most of the young youth, young generation. And 70 to 80% are predominantly the chest pains, strokes, respiratory distress, and other diseases. Nowadays, we have come across so many young deaths, like as Cinefield Rajkumar from the Karnataka, in Andhra Pradesh, there is an IT minister. Okay, recently, so many other deaths. One cine guy, Tarak, he also had a cardiac arrest. But because the immediate care was not given at the scene level, they had a loss of life. Some immediately, some after some time, after admitting into the hospitals. This emphasizes the crucial role of emergency medical care system. Across the specialties of non-communicable diseases, maternal health and child health, most of the conditions involve the time-sensitive emergencies, which is very important. If you start your care immediately in the field, you can save a lot. You can reduce so much of burden onto the nation also. And it is very important for the final outcome of the patient. So it is making a crucial link in the emergency medical care. Another disease control priorities data was suggests, like by WHO, 54% of the annual deaths in low and middle income countries can be prevented by effective pre-hospital care, facility-based emergency care. A basic structure exists in India. First it was started in Andhra Pradesh by our Honorable Chief Minister, Dr. Y.S. Rajshekar Reddy Garu, a 108 system. And slowly it has extended to the other parts of the country. Now almost it is there in every part of the country. Of course, few is maintaining another number. It is like a basic structure. They have started with a good intention, but it has not progressed properly. It is mainly just using as a transporting system. Okay, it has to be changed. And there is a need for the standardizing of the emergency medical care. It should be standardized and it should be uniformed. Okay, unifying the existing fragmented pre-hospital systems, benchmarking the quality, and molding as per the regional requirements, creating systems where it is unavailable. So, NELS is the course to take a first step towards the building this gap. So, purpose of NELS is, as I said, it is bridging the missing link and strengthen the pre-hospital care, build the capacity to respond effectively to day-to-day emergencies, and import on the hands-on training to the doctors, paramedic personnel, emergency medical technicians, and slowly it has to be extended to the general public too. Effective resuscitation of any kind of emergency is dealt by emergency medical care. You have to stabilize the patient during the pre-hospital care and transfer the patient to the nearest facility. Following the Good Samaritan's Law. What is this Good Samaritan's Law? Good Samaritan Law is, the law says if a person without any expectation of payment, reward, and without any duty or any special relationship, voluntarily if he comes forward to save a life, okay, he should not be targeted. He should not have any troubles after that. Okay, that's why India come up with 5 reasons to save a patient. Previously, we used to escape from the RTA cases, escape from the unconscious patients. Now, we have to save the patient. This slide, in my every talk, I will put this slide because it is very valuable. Okay. It says, if you save the patient, that person should not be tortured by the police, and there should not be any detention at the hospitals, and there should not be harassment about the medical bills. And this NELS course is conducted only for 24 participants in 6 groups with one instructor, that is 1:4 ratio. The medium of instruction, preferably English or the local language, because it has to be understood by the emergency medical care personnel. Of course, you have one course coordinator, 6 instructors, and 1 coordinator. Okay. And course director, 1 instructor and coordinator. The role of course coordinator is to maintain that, the billing, the things and all. Course instructor, he should have a good training and he should have a good authority on the subject. Next, course coordinator, he should coordinate the place. And after completion of this, of course, they may issue a certificate. Okay.
Sir, we are running late of time. And
just 2 minutes. So, the role of instructor is to be familiar with the materials, all these things, and create a good environment, healthy habits, and adopt teaching approaches to the experience. Prepare the participants and prepare the area to get a smooth one. Ensure the participants know supervise the participants, provide participants with timely positive and corrective feedback, evaluate the participants, and develop good, effective strategies to help them to meet the course objectives. And it should be a consistent, there should be a proper one. And this is the program schedules. It is a 3-day schedule. It's from the government of India. Okay. And the ratio should be 1:4, as I said. And the room should be with a good ventilation. And these are the things taught in a emergency medical care system. And these are the requirements. Okay. So, requirements. So, it's all supported by the central government to the trauma care units. Only thing is we have to start the things, start to teach the things. These are the faculty for the doctors. Initially started, now the faculty list has gone. Okay. And faculty for the nurses, faculty for the paramedics. It is started in every part of the country, in medical colleges now. Later it is extending to the other parts also. So let's start teaching your paramedics. Let's start the NELS courses in every part of the teaching institute. Thank you.
Thank you, sir. Excellent talk, especially creating such a wonderful course on behalf of Government of India. Since we are running very short of time, we will have discussion after all these talks. Now we invite 2 people who are going to present ATELC Kerala Model Part 1 and 2, Mr. HSD Srinivasa, as well as Dr. Sitarama Buddharaju. They are representing Tata Trust. Please.
morning. Actually, good afternoon. And it's always a very difficult time to take over and try to convey an idea before such an august audience. It's already saturated with a lot of complex ideas about emergency management and how to develop institutions around emergency care in the country. Very humbled to be here and very proud to be representing Tata Trust. What I would like to, again, when we were asked to give a small insight into what has happened in Kerala over the last 5 years in a public-private partnership, we just were wondering what is it that we should be able to convey. Today, I would just like to focus a couple of minutes on what is the role of private philanthropy in terms of developing public systems and how a TELC in Kerala is such an example. As you can see, philanthropy money is very limited and therefore needs to create a bigger impact by leveraging what is already existing within the public domain. Typically, the government is the biggest player investing into public systems for the larger public good. At the same time, there is also the intention from the private players to contribute towards societal improvement. Now, India had a tradition of philanthropy. Tata Trusts are more than a 100 years old organization, but more than that, we also have followed up. India is the only country to have enacted a law on CSR. And that's directly a result of all the, the kind of tradition that we would have had. Where should this money go is always a question. For us, at the, at the management level, the boards have been very creative in giving us the direction. So on 3 issues, the philanthropy capital is deployed. One is definitely towards individuals requiring higher studies or medical care. That's a traditional philanthropic mode. Second is institution building. Building institutions like Tata Institute of Fundamental Research or Tata Medical Centers. These have been, again, second thing. The third one was what we recently called innovations, either process innovations or product innovations. And therefore, we typically look for partnerships with organizations which can innovate, which can bring about a lot more efficiency in the system, which can bring about effective solutions to the fore. And the philosophy guiding us is this philosophy from Mr. Jamsetji Tata, our founding father. Over 100 years ago, he thought of sustainable philanthropy as a way to complement the public spending, that we should be able to rise up and invest into people who can be of further service to the country. And therefore, there's always been investments into centers of excellence. ATELC is one such. Again, I just want to look at what happens when we deploy this in the philanthropy in public sector, is that there is a problem statement, multiple problems. As you have seen, trusts have been involved in multiple themes, but problem statements are researched upon, the multiple solutions are looked at, a proof of concept is developed and deployed, and handed over to the right organization to take it forward and scale it up. And that's how broadly how philanthropic capital works. Again, this is just to show that the trusts over 100 years have nurtured almost 250 to 300 NGOs in the country. And actively in healthcare, we support almost 25 institutions across the country through philanthropic capital. What has happened in 2017-18 was that there was a discussion with the government of Kerala realizing the need that while Kerala is doing very well on all health indicators, as far as emergency trauma was concerned, they were also leading that in the number 5 in the country. And therefore, a proposal was discussed with the government of Kerala, and the government very graciously agreed to start a learning center. Why learning center and why not a service delivery center is like, we can go on and on. But a learning center which can set up the standards. The requirements were very specific, that across the state, we need to develop standardized care for trauma victims, and that's how the trust, Tata Trust came forward and implemented this program in discussions and in line with the need and requirements of the government of Kerala. Very happy that over the last 5 years we have had a very fruitful relationship in developing this institution, and a lot of exchanges, knowledge exchange have gone, and while the trusts have had experience in supporting another not-for-profit, which is the EMRI, in developing simulation centers, this is much more than a simple simulation center. This is an institution that has been incubated within the academic, and so what we would be looking forward to in terms of the next steps as we go forward, we think that this can become a good model for a lot of other states, other philanthropists, if they would want to develop these systems and a learning center as a nodal center in their own geographies. We have had a good partnership with CIHS, which was our operating partner, which did the entire infrastructure development and equipment, and also helped in the initial training of the nurses and doctors through the approved programs. We have also had University Hospitals Coventry and Warwickshire NHS Trust giving us periodic inputs. And this was regularly getting validated by the committees set up by the government of Kerala. So multiple modules have been developed at the center, aimed at frontline health workers with, along with nurses and the physicians and postgraduates of emergency care. We hope that this spurs this effort, ensures that it modifies it.
So you would like to take from what Srinivas has briefed you about the role of Tata Trust. Yeah, for us, what was the importance of this particular engagement? The Trust has been dealing with a number of organizations, number of grants and number of collaborations. But at the end, what is the takeaway for the Trust from all these things? It's not moving. There are some more slides. Yeah, the entire engagement with the government of Kerala started with a proactive approach from the government of Kerala in sometime during 2017. And the most important aspect of it is the engagement started from a very high level of the government functionaries. The health minister herself with her team visited Hyderabad and visited a couple of facilities that were helped with help from Tata Trust, like as Srinivas was mentioning, GVK MRI, which has a very good simulation lab, and again CIHS. Then we were encouraged, looking at the very high level of engagement from the government of Kerala, to collaborate with the government to come out with this ATLC for simulation training. And this followed the tripartite agreement with the government of Kerala and with the CIHS, who were our implementation agency. The key successes of this entire project was the continuous support from the government of Kerala, which was unique. We have been collaborating with a number of organizations, but as we saw, in spite of the delays during the COVID-19 epidemic, the steering committee meetings took off very well. Although we were not able to meet physically, there were a number of steering committee meetings attended by the chairperson ACS from the government of Kerala, which has helped us a lot in moving forward and to make mid-course corrections due to the disturbances that were caused due to the COVID-19. And that helped us to meet the planned targets in spite of these challenges. And we are very happy that we came out with a very solid proof of concept. So which has helped us, which has encouraged us, because we have to be answerable to our own board why we collaborated with and what is the outcome. This proof of concept, as you see at the ATELC center in the medical college premises, that itself gives that there is a very, very good facility that has come up with a lot of knowledge base. And some of the key has done a commendable effort to train number of participants, and in fact it has done more trainings than the intended number. And most of the trainees who were interviewed by this independent committee, they have responded favorably that the program has resulted in improving their skills, improving their knowledge, and they are able to work with more confidence in these emergencies. And majority of the participants said that it was very efficiently organized by the government system, the Directorate of Medical Education. And the training pedagogy was really helpful for the clinical fraternity in the area of this training center. And most important point from the trust perspective is, in any public-private partnership, the key element is sustainability. Once the collaboration is over, formally this particular collaboration with the government is going to end this month end. That is only a formal, but our informal collaborations will keep continuing. And there is, at the end of this, we are very happy that there is a very high element of sustainability for this entire engagement. And as per the report, recommendations of this IAS Independent Assessment Committee also, they say that there is a very high scope of integration of the training with curriculum for medicos and nursing students, and the scope of extending the training programs with niche areas like geriatric care, care at home, obstetric care. They are recommending that. And they say there is a very high possibility of utilizing these, expanding these ATLC type of models to other geographies. And the sustainability of this program is evident where institutional arrangements were created are robust, and there is a very solid foundation that has been made under this. And what we learned is the active support from the government makes the tasks easy and helps us to come out with a very good proof of concept. And the key element of sustainability has been ensured. I keep repeating it, that the key element of sustainability has been ensured. And we are in a position to share these learnings with other state governments and during our other knowledge management network meetings. We would like to take this opportunity to suggest to the government of Kerala that they may develop this facility into a national center of excellence for trauma care trainings, and to organize regular courses for all cadres, and keeping in view the Ayushman Bharat concept, particularly to primary health level cadres, health and wellness center staff, so that they can build more curriculum and they can make it into a national center of excellence. This would also help the government to come out with a revenue model, because it may not be very efficient, cost efficient for every state government to have a ATLC in their premises. They can save a lot of capex by deputing their cadres to such as National Center of Excellence. And then they may closely collaborate with National Injury Surveillance, Trauma Registry, and Capacity Building Centers. And they can even expand into IEC areas, Information, Education, and Communication areas, by developing more audiovisual aids, printing materials, publicity campaigns. And they can work with the Central Design Bureau for a more efficient and standardized infrastructure for L1, L2, and L3 centers of trainings. And they can plan more high fidelity simulation, which is already there. They have invested additionally after our support also in these high fidelity simulations. They can go with more standardized patients for these simulation trainings. And they can prepare for simulation trainings for emergency medical services for particularly large scale events, as has been mentioned in the WHO's presentation. They can focus more also in the simulation trainings for large scale events and make best use of the solid foundation in scaling up and expanding to become a world-class facility. These are our takeaways and our suggestions to the Government of Kerala. Thank you.
Thank you, sir. Excellent presentation, yeah, and you're doing a wonderful thing in Kerala. I have personally seen the facility. It's great, and in fact, it can be replicated in other states also. And we will take forward and make this a national center for excellence. That's what I hope. Now we'll go to the next talk. Dr. Brad Prakkar.
We will honor the speakers at the end of the session.
We welcome Dr. Brad Prakkar, President of New Zealand Association for Simulation in Healthcare and Emergency Medicine Specialist at Wellington Hospital, New Zealand, to talk on simulation techniques for training emergency physicians.
Kia ora, tēnā koutou, tēnā koutou, tēnā koutou, koutoa. So I'm an American, but I'm living in New Zealand. And I've been involved with the development of emergency medicine here in India for almost 20 years. I know a lot of people in the room. And I'm an practicing emergency physician, but I also am, my specialty is simulation, and I've been doing this for, again, 20 years. And I've done it in lots of different countries. And I'd like to share a little bit today what I think is simulation. And this is a bit of a misnomer, right? Because you talk about simulation, and simulation isn't just one specialty. In order for it to be effective, you've got to have nurses, allied health professionals, other specialties that go. And so it's not actually just emergency physicians. The way I'm going to do this talk, and I'm trying not to keep you away from lunch too long, is I'm just going to talk and just show you some pictures as I talk. So, oh yeah, this is where I'm from now. This is the kind of house we live in. We're all hobbits and we live underground. And we all play rugby and do dances like this, the traditional haka. Right, so what is simulation? And essentially, I'd like you to think about simulation as a tool. I imagine that everybody in here has at least some experience with simulation. And it's really based on educationally adult pedagogy and adult learning. And so as adults, we learn differently than we do as children. And reading books and studying works, but it's not very effective. Sitting here listening to a lecture, what you actually retain is quite little. Almost only 30% of what you say will actually be retained. Having said that, all of you went to high school, you went to medical school, you did your undergraduate and postgraduate training. Where along the line did you become a teacher? I think there's very few of us who have actually went that extra mile and have gotten an educational degree. And this talk, I think, is really well suited. We had Dr. Sagar talking about a global perspective and Dr. Siddharth talking about faculty development. And this is further on faculty development. And you as a practitioner or a teacher within your program, it is something that you can actually use to develop your skills, but also a much highly effective way to teach other professionals. So speaking of that, you think about professional athletes, professional musicians, composers, pilots, nuclear reactors, they all practice. Why don't we? It seems sort of silly. We would practice medicine, but do we actually practice practicing medicine? And the answer is most of us who are gray hairs in here, or no hairs, do not. And should we? So, you know, this is a teaching medium that is contextual and it's based on your learning objectives. And what we try to do is put learners in a situation that they're not necessarily used to above their current skill level, but we do it safely with a risk-free realism. And what we mean by this is that there's no risk to the patient, but also there's no risk to the doctor either. So what you use simulation for is things like physical exam, diagnosis. You can teach procedures on task trainers, inter and intra professional work, team training. You can even use it for morbidity and mortality, recreating the cases and seeing what happened. And also, the truly holy grail of emergency medicine is systems training and testing your systems. And to demonstrate that during COVID, we found when we were doing studies on how to move patients around the hospital using simulators, we were able to save hours of work by actually mapping out things using simulation. And it really was an effective way that we actually learned things. So when do you do sim? Should you use sim for everything? Should you use sim for all of your teaching mechanism? And the answer is probably not. It's a very resource-restricted educational system. It's expensive, both in time and money, but also space. I mean, who here's emergency department is not full these days, right? And how do you get that space to do in situ training? But also it requires some expertise that is something that you have to develop. It's not something that is inherent within your training that you would have had at some point in time. But it also requires a technical aspect. And in my center, my team, we have a team of 6 technicians and educators who help me run things. I am the president of the New Zealand National Simulations Association. And our biggest priority is actually developing technician courses and trying to teach people who are non-physicians the technical aspects of running a simulation scenario and working within a simulation environment. So one of the things that I'd like to talk about is what a mature simulation program might look like. And really, ideally, it would be embedded in your curriculum. So it would be either parallel or opposing to your didactic, whatever your didactic curriculum is, or it could have its own curriculum that you would set to do specific things. And it should be sim-specific. You can use it to look at usual or unusual complications of common or uncommon presentations. You can look at it to use for protocols, algorithms, and new policies within your different departments. Obviously, team training is what we've talked about and heard a little bit about before. But if you think about it, how do you train someone to work together in an ad hoc team in, for instance, like a trauma scenario where different people come down at different times? So it's not about the actual team. It's about training people and giving them skills to actually interact with each other. And that's really where the value is. You can also use it for new equipment. As I mentioned, it's a really effective way of doing a morbidity and mortality review in a way to help understand the decisions that were made and the mistakes that might have been made. And lastly, I mentioned systems testing, which is, I think, probably where it has the most value. So the next question is, what do you sim? Well, and where? And so most things are simulatable, but not all. It's really not a great way to disseminate facts. You can learn that from a book. You can be taught that. That's actually quite easy. you really have to use a prima facie approach and ask, does this actually make sense? So does this topic or concept that I want to get across, would that be best served by simulation? Or conversely, asking the question, is this idea that I want to teach, is my learning objective simulatable? And that may or may not be the case, but you really have to ask that question. And so when you're designing these scenarios or thinking about whether or not you're going to use simulation, I like to break it down into essentially two categories. You have technical and non-technical. So technical would be things like procedure, actually doing things, making a diagnosis, investigations, working out a problem. Non-technical, I think, are actually much more useful for simulation. And these are things like communication, interprofessional, psychosocial interactions, delivering bad news, things that you might consider soft skills, but we call them soft skills, but they're actually quite important and a really important part of what it is that we do. So part of this slide was where. So, we have a airplane simulator in my sim lab donated by a philanthropic interest. And we have because of the geography of New Zealand, it's a very disparate and difficult, a lot of rural places. And so we have lots of air transport. And so we need to train our technicians and our physicians in the airplane. Ideally, if you want to do simulation well, you should do it in situ, and you should do it in your ED. You should do it using your own equipment, your own staff, your own familiar area, rather than trying to recreate a simulation in a simulation center or a conference room where half the time during the sim they're trying to figure out where things are and what's located and what tools they have. But there are inherent dangers in that, and I'll talk about that. So, what not to sim? Well, it's actually a pretty important thing to think about this. You don't want to put a round peg in a square hole. And again, as I mentioned, facts are probably not the best thing to be taught. But I think that the fidelity of the mannequins, I've been doing this for 20 years, and quite frankly, the mannequins haven't really changed all that much in the last 2 decades. And there are technical limitations to what you can do. And so they have limits, and you have to recognize those. You also have to recognize that some people will just not buy in. Some people will not want to play. This is not them. There's any reasons they've had a bad day, or they've had a case that had a bad outcome that was too much like that they were doing. There's lots of different reasons why, but some people just won't do. It can be raw. It can be very confronting. I run a course for physicians who have gone on leave. The vast majority of them are maternity, and they come back, and purposely we do show them or do have them take care of sick children. And that can be really confronting to a young mother, or a father for that matter, dealing with that. And part of the scenario is not necessarily them doing the medicine, but how they're going to deal with those emotions, having just had a baby, but now actually taking care of a sick one, and what that potentially might mean to you. And the last thing is the debriefing. And so you've heard about debriefing. That's where a lot of the learning comes in simulation. But there can be a real danger if you don't know how to do it, or if you do it poorly. And it's really a skill that needs to be learned and practiced. And it's not something that you should take lightly, because it can affect the people that you're teaching and have bad outcomes. So having said that, talking a little bit about the pros of SIM. Well, it's repeatable, it's controllable, you have defined learning objectives that you actually can use. It's quite useful. The fidelity of the mannequins actually is okay. They are getting better, and there is an element to it rather than using a standardized patient, although we do use standardized patients in conjunction with the actual simulator. But you're dealing with adult learners, and they have adult needs, and part of those are social issues. So training with a team or training with your colleagues, it's a social thing. And certainly post-COVID, everybody has a need for some social interaction. And it lets you work with your colleagues in a safe environment. Other pros are that you have a lot of, you can practice your skills, your technical aspects, and in a mature program, you can eventually do testing. For the Australasian College of Emergency Medicine, our exit exams are simulation-based. So some of the quick cons is that it can be labor-intensive. You have to plan it. The idea of a guerrilla sim where you just show up and do a sim on a ward is not a great idea. There is limits to the fidelity, and that is also a problem. Bear in mind that if you do lots of repetition, that actually may turn off some more advanced learners. There's this idea of hypervigilance where everybody's in the sim and they're waiting for the sim man to crash. And in fact, that's not what's going to happen. And it's not necessarily what actually happens in a real scenario with a real patient. And so there is some loss of fidelity along those concerns. If you practice in situ medicine, in situ simulation, there are some inherent concerns that you'd have to be worried about, and those are leaving fake drugs or using up real drugs. One of the instances I had is I had a registrar open up a $1,500 bottle of TPA in a stroke simulation. I didn't win any friends for that. And the last thing, what I think you need to be aware of is this idea of negative transference. And the concern with negative transference is if you have a simulation and someone does something wrong, or something is omitted, or there's a problem, and during the debrief you don't call it out, you don't identify it, you may get a pupil who walks away from that simulation thinking that that's okay. So a simple exam was you go ahead and intubate someone, but you're not wearing gloves or a face shield. And a junior may walk away and say, oh, well, I don't need to wear gloves or a face shield, and that's obviously a problem. So this is just a quick thing. We hold an instructor course 3 times a year for different faculty, and we have a strengths, limitations, and cautions. And every time we do this, they're similar but different, and the list always grows. And I think it's just important to really think about what you're doing when you are going to use simulation as a tool. So look, this is what we want to prevent as a takeaway message. And I'm going to actually go a little backwards and give you the statement that I always give before we do a simulation. So everybody comes to work every day as a professional to be the best person, to be the best doctor that they can be, or nurse, or allied health professional, right? And if you start with that as your baseline, I think you only go up from there. And I think it's important that you think like that. So I'm just going to leave you and not keep you from your lunch anymore. But I think this statement is true. And this statement actually, this exact statement is on the wall of the ATLLC Center, which I was really pleased to see here. Thank you.
Thank you very much, sir, for this use of this simulation techniques and the skill lab development, the pros and cons, and when to use, when not to use. And in our setup, we have to analyze cost-benefit analysis. Based on that, all these skill labs are developed in all the stations in our medical colleges. And in small setups, I think by local iatrogenic models can be innovated. For example, starting a IV line skill, that local things can be done instead of buying a model available, because it's based on the cost-benefit analysis. And really thank for this session. And definitely our skill labs are functioning in all the medical colleges. And even small setups can be done in the district headquarters or hospitals also. Thank you very much, sir.
We will honor the speakers, Dr. Nurullah and Dr. Srinivasan, please come.
I request Dr. Noorullah.
Dr. Nurullah, sir, please. And this is actually for regarding the NL's program you have discussed. It's most important thing is a team effort, actually. It's not only doctors, paramedics most important, and all to be trained properly. That aspect is accepted, and all the nursing, paramedics, everybody is a multidisciplinary approach along with the team effort. We are trying to save the lives. Thank you very much for that. Thank you. And regarding the Tata Trust, extraordinary support from Tata Trust for this Kerala team. I'm really happy. Without public and private partnership, it is not possible. We cannot fulfill the societal health needs, especially emergency needs. And thank you very much for that, sir. Thank you.
We invite Dr. Patanjali Dev Nair to hand over the memento to our chairpersons, Dr. Mohanan Kunnumal, Dr. Shanti Mala Ramalingam, and Dr. Vijay Vasantrayosa.
We request Dr. Shanti Mallar to kindly come onto the stage to request her. Thank you, Patanjali sir. Now we will be having a lunch break, and we will reassemble here at 1:45 p.m.
Ideal response time, already developed on that, and how would seamless care be ensured during transport. I think we have to leverage technology. 5G technology is available for seamless care, for seamless delivery of data without any latency. Also, we can look into drones, which I mentioned during my last talk. But the weakest link in this whole thing is trained manpower, EMT. And I already mentioned last time that there's a requirement need analysis, oversight, data analytics, audits, and more importantly, need for central command telecommunication center. So what do we mean by central command telecommunication center is this. We have a call center now operated by an ambulance service firm, if I may use the word, an agency. The state government does take a responsibility. They have a situation where there is a central oversight, they're posting doctors there, but they're monitoring the data provided by the agency, and they're trying to analyze that. What we required is a robust oversight mechanism consisting of doctors, public health specialists, monitoring officers, analysts, actually real-time analysts, who can do teletriaging, hand-holding of EMTs, and monitoring services, data accuracy and analysis, and this should feed into policy and research. So we should be responsible to ourselves to say, 3 months hence or every quarterly, what improvement we have done based on the data what we got in providing ambulance services. Because the public is not going to ask for it. Public is already happy by seeing an ambulance, but we know what needs to be done. Typical example is this. I just took from the Australian St. John's ambulance. Just look at the data which comes out from there. This is a report which they publish on a very regular basis. 3 persons per day have cardiac arrest, 70% occur in private residence, 21% of them survived, had a pulse, 79% received bystander CPR, 5% received defibrillation. 9.1 minute is the median time, response time, 13.3 minutes is what the time took for patients. So this type of data, this type of analysis, this type of thinking has to come into our system. Unless this happens top down, we are going to be happy what we are. We are happy just seeing an ambulance, seeing an EMT. We don't know what the EMT goes through in his mind. We don't know what exactly is happening. And the ED staff is happy receiving a patient because they know the patient is coming and they try to do whatever needs to be done, thrombolysis. But exactly from the patient's perspective, what has been lost? Who's capturing that? This goes in for further. We require research. We require a good template for research in various settings, for various conditions, for various critical processes, and for various aspects of pre-hospital care. So to my understanding, it is a HRH that is the most weakest link. Other things can always be scaled up. SOPs have to come once the HRH is there, and they need to be trained. And we need to do periodic quality improvement analysis for pre-ambulance research, for the pre-hospital care. Again, from Australia, the need for AEDs. I was just discussing with one of the manufacturers in the stall. There is no policy in India, I believe, for putting AEDs in public space. Citizens require education. So you see the bystander AEDs used in Australia. Some other examples of good research are some of the studies published like this, which mentioned that higher number of ambulances also with better survivals. In Paris, they divided Paris into various zones and saw how ambulance reached. Another example of good research is from Sweden, which mentioned what should be an ideal response time. This all came from pre-hospital research. They're all published, well quoted. Why can't we have our own pre-hospital research papers coming like this in reputed journals to inform us? Building blocks, we are all aware. I had to tell this August audience what it means. We have a patient, we have a GPS-enabled system, we have a patient care during transport and transfer, trained operators, and what we're looking for is a command telecommunication center which can handhold it EMT during the particular triage. It may look very simple, this particular slide, but to make it function optimally, I think a lot of work needs to be done, and we have to do a lot of thinking. We also have to put in board ambulances, bike ambulances, and air ambulances. And we require a robust governance structure. This I took from the Tamil Nadu government system. They have made a commitment towards this a couple of years back, and they have put till the last mile, they put a governance architecture in place. So our suggestion is that we should also have an oversight under the national oversight, under the NHM, who also monitors this and publishes this report on a regular basis of what the various state governments are doing as regards the various emergency conditions and the outcomes. I think this type of model is required for us to progress to the next level. HRH again is critical. Again, I'm just mentioning the HRH training that is being done in various countries on the left side of the slide. I won't go into the details. Also HRH in the call centers. Many European countries have nurse practitioners and doctors in call centers because that is the most critical part of the emergency care. These are the SOPs which the EMTs have to follow. Again, these are the various summary of pre-hospital interventions that need to be done. And various type of triaging. The EMT is supposed to do at least 2 to 3 triaging before reaching the hospital. These are the various processes that has to be followed, and they require hand-holding and monitoring. And we see the number of courses in India for paramedics. This is a summary slide. Actually, this took a lot of time to make. We have around 17, we have a certificate course, we have a diploma course, we have a UG course, we have an online course, and we have also the ATLS programs. Run by 17, 20, 24 organizations, each one giving their own certificates. It's good that we are looking into this aspect and we are trying to scale up this much needed healthcare provider. But we also need to realign and relook and think about the skills that they develop and align with the National Commission Allied Healthcare Professional Acts Bill. So we need some ownership from this society to take forward this agenda, to put it across to this commission so that it gets streamlined and we can have a good EMT paramedic workforce. We can enable 5G. This is from one of the 5G companies. They have key features. Ambulance ecosystem is already developed. They can view the ambulance, command telecommunication center, and live video consultation keeps happening as the EMT says. So, like things like requiring the neck stability, requiring CPR, repositioning during CPR, giving IV fluids, all these can be viewed by the doctor and they can give a live consultation. Models are developed for hub and spoke model. Many states have done this. We also have models for mobile stroke units like in Assam. And also technology for Uberization model. Some states have an Uberization model to rope in the private ambulances so that they can pool for a common cause. So briefly, these are my last few remarks. Many states have made uneven progress. Kerala, Tamil Nadu, and some states like Gujarat are in the forefront. They should go to the next level, not be happy with where they are. They should be leading others. Most of them are driven by PPP. We should have a rigor of memorandum of understanding. Like Tata Trust and others can help us out in making a good rigor MOU, a mutual commitment. Ambulance density definitely requires augmentation with either fleet, increasing fleet capacity or by Uberization. GPS tagging of ambulance is the first most starting point, which we all need. I'm talking about countrywide need. We require a uniform call number. Public must be made aware of ambulance services. They should be told to use ambulances to come for attending emergencies, not rush in any vehicle. Specific apps are required, and traffic in metros is a challenge. Optimizing response time should be based on triage, and we should try to explore first responders, and we should try to involve community for first responder response. Trained EMT, again, requires skilling, reskilling, and we should also train the drivers of the ambulances to provide EMT. Like I think Australia is already doing this, and they have 2 EMTs on site. Robust command telecommunication center is a need of an hour, and technologies such as 5G needs to be leveraged. We require data collection, ambulance systems, and hospital connect. So the framework, which I mentioned during my last presentation, I'm putting it over here. In addition to the framework, which research is one of the foundation stones for it, we also require legislation. Good Samaritan guidelines have to seep into the population. We can also think of an EMS Act so that we can increase the scope of Good Samaritan guidelines to other emergencies also. A lot of regulations, legislation which many state governments have done for road traffic accidents, driving lessons, and other aspects. This is my last slide. Why focus on pre-hospital care system? This is for us and for all the important stakeholders over here. This is from the NHS system. See how the cost escalation keeps happening. Dr. Bhoy already mentioned in the AIMS study, around 30 to 40% of hospital admission or hospital beds in any time is filled by patients brought in from the ambulances. Efficient handling of the patients before reaching hospital by discharging them on site or by doing good telecommunication that requires a good command center can save huge spendings of government on healthcare, right? So 1.3 billion is spent on ambulances, but when it reaches hospital, it reaches 3.8 billion cost. So huge cost savings can happen, and you also reduce a huge burden on hospital. So it's a win-win situation for the health system also, and obviously for the patient. Thank you so much for patient listening and for this opportunity.
Thank you, sir. Now we will have a short discussion.
I think due to the we are running short of time, so we'll have the next topic right now, and we'll have the discussions at the end. I'm sure that we'll have so many things to discuss on this. And may I call upon Dr. Bimal Krishnan to talk on building an academic pre-hospital care program in India. Dr. Bimal. He is Associate Professor in Emergency Medicine, KEMS, Manipal.
Check. Good afternoon, everyone. Thank you to the respected chairs. Thank you to Vishwanath sir and the organizing team for having me here. A pranam to all the teachers and mentors here. I'd start off with a small story, the story of my marriage. Start off with a small story, a story of my marriage. I got married in Trivandrum. It was 10 years back. So on stage, my uncle collapsed. So we were like this in the center. He came over. I turned back to talk to my wife. My uncle collapsed on stage. So it happened in one of the premium wedding centers here. We started CPR on stage. My friends, including my senior colleagues here, came half an hour late for the wedding. They heard my noise. 1, 2, 3, 4, 30. Gave 2 breaths, come back. My wife was holding his legs up. We continued resuscitation. The place had an AED. We defibrillated him, I think 4 times on stage. Defibrillated him 4 times on stage. By then, we had an ambulance coming in. We had an IV line in place. We gave 2 shots of adrenaline. I walked over to the ambulance. I got into the ambulance. That is when Sir had tapped me in the back with Dr. Jairaj, who was also there. Tapped me in the back and said, Vimal, you got to get married. We got ROSC, or return of spontaneous circulation. Thankfully, uncle lived. But that was a horror show because the cameraman collapsed. We couldn't get the footage on TV. For a long, long period of time, I used to be known as a guy who did CPR during his wedding. And that was the pre-hospital care that we provided on the day of my wedding in this place 10 years back. So we're not primitive. We're just not guided enough to do well in the pre-hospital care setting. I'm Dr. Vimal. I'm a faculty in the Department of Emergency Medicine at KEMS Manipal. Why I'm here is because I'm also a person who was there in the special committee for the Manipal College of Health Professions in designing and starting off the bachelor's and the master's program for emergency medical technology. Emergency medical technology, I repeat again, because I've been hearing a lot of technician words being flung around, emergency medicine technologists. And rightly so, sir. You had specified that in your discussion in the morning also. I've got no disclosures for this talk. Although I teach a bit of trauma, including ATLS. I've been teaching ATLS for the last 12 years. No other disclosures. I'll just talk about a bit of history of EMS systems across the world and how it's happening in India. Variables to consider when we're moving forward and some innovative solutions, specifically on the academic forefront. The evolution of EMS has been very, very patchy, anemic in India. But if you look at the whole world, we're not very, very far behind. It's just that we didn't have the processes in place. Do we have the manpower to do it? I think we're slowly reaching there. Slowly but surely reaching there. But as said earlier, it's always depending on a lot of historical, cultural, and economic factors of that land. 1965, the white paper was released. The white paper defined the magnitude of the problem, spoke about accidents, disabilities in that region, specifically in the US. They spoke a lot on the economic and the social costs associated with them, which was very, very eye-opening for the whole world at that point in time. It even led to the formation of the Highway Act in the US, led to the creation of the US Department of Transportation then in 60s. Europe, I think Brigadier Venkatraman has already touched upon how the system is with the NHS and the UK. It's a centralized system that they use with physician-led ambulances. When I've been in Scotland, we've had first-hand review of how that system works. But when you go back to Germany or other countries, the Anglo-Saxon, the French, German, they've got a different system in place where it's provided both by the public and the private providers together. The challenge with India, we've got a mix of both. We've got the scoop and run, the stay and play put together in place. Just that we don't have the necessary accreditation bodies to look into that whole process per se. So I think all the developing countries, including India, we've been adapting and innovating according to our needs specifically. Not working. Yes, now. So this is a seminal white paper which the NHSRC had come out with and spoke about EMS in India, services in India. The concept white paper spoke about the heterogeneous state with which EMS is floated across states in India, the absence of a nationwide system. We spoke about the lack of a nationwide number. White papers coming on with different recommendations for numbers that we should have at our proposal, but then there's a lot of public-private partnership coming in. There are lots of firms coming in, different stakeholders with different vision, different intent coming in. Healthcare schemes which vary from states. I worked in a couple of states, entirely different body of work that the governance there would want us to do. So healthcare schemes, again, different. Initiatives in the state, again, different. The other big challenge is, what is a paramedic? Words are being flung around. If you look at the article from this paper, in India, it's used interchangeably with a lot of other allied healthcare professionals. We've got respiratory therapists coming, got physiotherapists coming in. It's just been too much of confusion with these semantics. This article, however, recommends the development of a standardized framework for training, education, and that would in turn telescope into better quality of care in the long run. A very good, a total overview of what was happening and how to move forward with regards to what we have in our system, the numbers that are there in the system, the 108, 102, 1098, the 112 that we discussed in the morning, the CAT system that Professor Dr. Agarwal had spoken about in the morning. They've touched upon everything here. They've also touched upon the problem that we have, the problem of plenty in India, with plenty of confusion with the variability that exists in EMS education. Specifically in the education front, basic, advanced, paramedic, pre-hospital trauma technician, diploma trauma technician, PG diploma in EMS, and so on and so forth. We saw the last slide that Sir had presented, and the work that you had to do, Sir, to compile everything put together onto that slide. It's a very commendable slide because in India, you've got more and more coming in, more and more added each day with different vendors coming into the market. The biggest thing that could come out of this paper, however, is the implementation of community-based EMS systems, a good take-home point for us in India, increasing public awareness, utilizing resources for training, leveraging technology, mobile applications which is touched upon, telemedicine, another forefront which we're going up, and I would say add one more thing, AI to it. I see lots of students using ChatGPT today. We're not far away from a system where you've got integrated ChatGPT scripts coming into systems which are centrally mounted in hospitals or in care centers per se. AI would sort of give us a lot of leverage on how to make care more accessible, more easy. That white paper that we've done from the Indian context, they spoke about a legal framework, information system, health education, training, and governance. My focus would be on the training part, but we need to talk about governance because it can't just be delineated per se. When you look at policy changes, there's a Highway Trauma Act that came in 2007. There's a Good Samaritan Act, just to name a couple, a Good Samaritan Act. So we need more and more people to be aware, more and more of the public to be aware of the acts that are coming in that could make an impact on how they would care at the forefront. We've been teaching a lot of community care providers, World Heart Day, there's CPR that's been taught. There's a lot of training on first aid and safety among school children that catch them young, something that I learned from Professor Dr. Bowie. Catch them young. We've trained 3,000 plus school children over the past 3 years. So are we looking at training them, or do we need something to come from the top, a top-down approach where it can trickle down and tell them, you need to not just train, but you need to have acts in place where people need to help others on the field and not just take up a video with their mobile phones. The 2017 white paper, which I had the good fortune of being a part of, along with stalwarts in the field, we spoke a lot about how to operationalize mechanisms, how to establish standardized regulations, accreditation pathways for operations and care, specifically in the pre-hospital care spectrum. There were lots of challenges that were cited. The biggest challenge that we found was the bachelor's course doesn't come under a single board or a council. When we talk to different regulating authorities, again, states, it's a state subject, we do agree. Different states have different modes of operations. Depending on the institution or the region, standardizing the curriculum and requirements, again, we've reached dead ends by hitting on different regions and talking a different language. The institutions and the regulatory bodies involved with offering such a course needs to ensure that there's a necessary requirement and standards, and who is to accredit, who is to take care of that recertification, that accreditation part. Big questions for us to ponder. So what we thought was a comprehensive 5-pillar approach, a well-defined pre-hospital care model, which was touched upon earlier by Sir. Trained workforce, again, the biggest rate-limiting step today would be to have good trained workforce. Communication system with technology integration, now with 5G. I think we're going into an era where we would have non-latent technology seamlessly integrated into systems. Medication and equipments, we need a lot of money for resources, and it's not easy. And we need to chart it down in a way in which these are going to make a big translational difference on the field. And finally, the good governance and good advocacy for the same. So when I spoke to EMTs across India, when we spoke to them, they always say that we need a needs assessment for EMTs across the country. They don't have a registry of their own. There are people who are working with us, training the bachelor's degree, who've done their basic EMT 5-8 years back, come in, they've been with us, they've been teaching with us, but they still don't know how many of them are there in their tribe. And are we looking at a dwindling population because there are people who are eroding off and moving to the west for better job opportunities? Are we looking at establishing a pre-hospital care registry? Registries in itself is a very scary proposition. We are part of a national task force where we did a study which was funded by ICMR when I was there in Thrissur almost 6 years back. Again, Sir was the lead for that with Professor Dr. Amit Gupta. We found out that there's a huge gap. There's a huge gap in the way pre-hospital care services have been delivering care, have been training those personnel, including the drivers who were part of that whole gig. We tried an intervention by training those drivers on how they could impact, how they could create an impact on the same, and we found out a significant difference which was published later on. We need a clear leadership and governance with regards to establishment of a pre-hospital council, delineating funding and resource allocation plans, standardizing training, more importantly, pre-hospital care delivery system guidelines. So what we suggested with the Ministry of Health and Family Welfare, creating a national pre-hospital EMS council, for the state group to form a state pre-hospital council, work together, and NABH to continue with the quality accreditation process. Just a quick look into how we can push the education aspect of it, the EMS education aspect of it. Periodic updates on 3 documents, a national EMS core content register, an EMS scope of practice register, and an education standards register which needs revision regularly. At the end, it should lead to an EMS certification which is nationally controlled and accredited also nationally, at a national level. If you look at academics, the quality of care that we provide on the field, the day we provided care, we had more than 12 personnel with various years of experience and training in emergency medicine, and we could provide decent care on the stage prior to being shifted to the ambulance. The biggest challenge that we have today is lack of trained personnel for pre-hospital emergency care, ensuring well-established, standardized university-level courses and not just fly-by-night courses. First responders should be uniformed, regulated, and trained providers, and we should stick to it. We can't cut corners around that. So we've started a 4-year undergraduate program. We've got 4 batches now. We've also started the master's program. We've got a couple of batches in the master's program also. We've done an outcome-based framework for curriculum, and whoever has come to us, there are multiple institutions which have come to us, discussed with us, and taken off the curriculum, and they've started on their own, and we need this to form a snowball effect on EMT education across the country. These are the first 3 batches together. Dr. Preston, who's an assistant professor with us in our department, is the nodal coordinator for that course. In the long run, we don't know what would happen with academics, but we need to ensure that EMS is a specialty in itself, encompassing administration, clinical protocol development, resource management, disaster health, EMS fellowship is something that should come after your MD in emergency medicine or DNB in emergency medicine, where you can take up EMS fellowship and then come back as retrieval medicine directors or pre-hospital directors for your hospitals. Become the pre-hospital care director and set up an ecosystem which not just focuses on education alone, but for good care delivery, integration of technology, and definitely advocacy of pre-hospital care in the system. Healthcare, the biggest challenge with EMS is that they are at the junction between healthcare, public health, and public safety. Imperative to have innovative solutions. Some of them have been discussed earlier by Sir. I just touch upon a couple motorcycle ambulances from Malawi to India right now. We've got multiple cases which have been, multiple studies which have been written in literature. Again, from the UNICEF website on India's remote regions having motorcycle-based care. They've even given pictures of what we've been doing till now. Motorcycle ambulances and electronic vehicle-based systems would be the future. Community-based EMS systems with a lot of tie-up with the fire department, other community-based systems where we can train and use people like seen in Brazil. It's already been published. Registries for EMS practitioners could be a step one to start off with, and stakeholder engagement with the right people at the right time. Changes at the systemic level are required if you're to move forward and form a reliable, safe, and patient-centric model. We need a comprehensive approach, not just look at education as one aspect alone, because there's a domino effect that happens. We need to build accountability from all the stakeholders involved. Commitment from them would be warranted, and we need integrated systems for EMS. And not to forget that it's not just EM, emergency medicine of the hospital. EM has got such a big umbrella that pre-hospital systems should be under the bigger umbrella of emergency medicine per se. I would like to draw your attention, just the last couple of slides, attention to the line from that website, where they said you need to bridge the last mile to healthcare. I don't believe pre-hospital care is a last mile to healthcare. I believe it's a first mile to appropriate care that you or your vulnerable dear ones can receive. And I believe the worst days of your life, you can't choose a doctor. You're coming to the emergency department. You need trained personnel on the floor. You need trained personnel on the field to provide adequate care. And that would be the last piece of the puzzle if you are thinking of integrated healthcare services specifically for the sick victim. I searched a lot to find out care provision by Indians in the emergency medicine field. This is an image I had created using AI for an Indian providing care to an Indian. And sadly, we don't have that. And I don't think we are far from a day where Indians would care for Indians, and we won't depend on the West for pictures for the provision of adequate pre-hospital care in India. Thank you. Let's all believe that we can be the change that we can induce.
Thank you, Dr. Vimal Krishnan, for that exhaustive talk. I'm sure a lot of queries will be pending, which will be answered towards the end of this session. So the next, I call upon Dr. Atul Mohan to talk on quality accreditation in emergency medicine. Over to you, sir.
Thank you and good afternoon to all of you. Thank you to Dr. Vishwanathan and his entire team of KEMS for giving NABH this opportunity. Thank you to Dr. Bhoi, Dr. Praveen, and the entire team for sticking with us, Dr. Sagar, for their patience. And thank you, respected chairpersons, for this opportunity and allowing me to jump the schedule. Most of the doctors today are not aware about what exactly is NABH, what exactly is accreditation. They are very well aware about accreditation systems in medical education, but as far as the quality systems in healthcare delivery are concerned, they're not aware. So what exactly, please allow me to briefly introduce the organization which I'm representing today, National Accreditation Board for Hospitals and Healthcare Providers, what it exactly does, what the umbrella body under which we operate, and then allow me to come very briefly to the emergency certification standards, which are quite old with us. So NABH today is part of the Quality Council of India umbrella, known popularly as the QCI. And QCI is an independent autonomous organization under Ministry of Commerce, DPIIT, Department for Promotion of Industry and Internal Trade. And it was set up in 1997 by Government of India when it came together with all the major industry bodies, CII, FICCI, SOCHM, to create an umbrella body with one single line mission and vision to create an ecosystem for quality in all domains related to everything which operates. The chairman of QCI is appointed directly by Honorable Prime Minister of India, and the first chairman was Shri Ratan Tata ji. So the Tata Trust, which operates this, that's a thing. Very few people know, and that Shri Ratan Tata ji laid the foundation of the entire quality movement in India. And since then, equally illustrious people have held this post, TVS, Velu, lots of them, and they've all succeeded and created this system. So these are the aspects with which it was considered, and to fulfill each aspect of the mandate QCI has been given, the further subsequent boards, etc. have been set up to establish and operate, to conduct, to run, to catalyze, to develop, augment quality. And for each word, there have been to establish and operate national accreditation programs. So there are 4 boards which have been put up just for that. NABCB for certification body, NABL you may be familiar about, which takes care of not only medical labs, but testing labs and calibrating labs also. NABH takes care of the healthcare part, and education and training, including higher education, is taken care by NABET. The third party assessment to measure quality, there's a whole lot of project planning and implementation divisions. So total about 1,000 young and old workers are operating out of Central Delhi and Gurugram to fulfill this mission. This is the governing structure. There's the governing council, governing body, 4 boards, 1 quality promotion board, very whole lot of special divisions which operate a variety of programs from coal to quality of fisheries to operating and mandating the drone program, for example, the entire Swachh Sarvekshan for past so many years, the entire open network for digital commerce, the assessment of various nursing colleges, etc., etc. So it's a very big mandate covering end-to-end spectrum across various divisions, policies, and ministries. This is the current leadership. We are led today. I told you the first chairman was Sri Ratan Tata ji. Today, the QCI at the helm is Sri Jakshish Shah. And our Secretary General is Dr. Ravi Pratap Singh. They're all educationists of repute and otherwise leaders in their own right. And all the equally illustrious people have held the chairperson of the board also. These are operated like a corporate structure. There's a profit and a loss, but the single line mission is to reach and touch every citizen of the body and take quality to the last in the line. That is the simple thing. Creating an ecosystem for quality is the vision. We are a big country. So today has been a day of learning for me, and it's been a fantastic opportunity for me to see at close range how foundations of a huge, fantastic systems are being laid. Not today, I think, as Dr. Vimal also said, we are not primitive, we are just trying to tie the loose ends. So for the past 20 years, as Dr. Sagar very eloquently mentioned, very passionately mentioned, that day by day, year on year, they are trying to forge a system into place, which takes time. So we are not one country, we are 36 countries rolled into one, and it's not easy to do anything. But still, I think it's a phenomenal thing. The journey of NABH came about in 2005 when it was founded. So QCI was formed in 97, about 26 years back, but NABH was formed in 2005. When prior to 2005, the entire concept of quality in healthcare in India was largely textbooks based, only theory, no practice. And in 2006, what changed was that Indraprasth Apollo got itself the coveted JCI accreditation. So there are few accreditation bodies in the West. Like JCI is the oldest one, about 72 years old. It was formed in 1951. And since 51, they have been releasing standards. And it's very expensive to undertake a JCI accreditation. So there was lots of hue and cry in the press that foreign exchange drain is happening. So that's why Government of India requested QCI to create a national body, and thus NABH was formed. So 2005, NABH was formed. 2006, the first standards were released. And every 3 years since then, a set of standards are released. The values on which the NABH is formed is credibility, responsiveness, transparency, and innovation. And these are the values we adhere to, and every day, day by day, we try to weave in more of that. We are open to RTI, we are under RTI, we subscribe to all queries. There's a very robust grievance redressal mechanism, and all our new programs are very, very low cost. So this is just to show you the structure of board, just to highlight that we have a accreditation committee, technical committee, and a secretariat which collates all these things. There's an international umbrella body called ISQA, which is registered in Dublin. Earlier used to operate out of Geneva, but since COVID, it has now moved back to Dublin. And that is the mother body which controls all the accreditation bodies in various countries. There are not many. Most countries in the world today do not have their healthcare accreditation standards. But India is proud and privileged to have these standards, which are totally self-reliant, Atmanirbhar, and they are there. We are into 19 years. We are still a teenager, but we are a 19-year-old body. And today, we are proud members of ISQA, not only our standards, but also as an organization, we are registered or accredited by ISQA, and for the past many, many years. These are the core activities of NABH. We accredit healthcare facilities. We do IEC activities. We do lots of trainings, free and paid, heavily subsidized courses, which are certificate courses, which are very, very popular. And we also do quality promotion. We also do recognition, endorsement, and we own various marks also. This snapshot is very important. This shows you what today NABH does. So starting with that one program in 2005, today we are running about 25 programs. We are continuing to add to these programs. For example, there are 3 broad headings. We do accreditation, certification, and empanelment. So under accreditation, we touch today about 3,000 facilities. These are all large multi-specialty hospitals, both modern medicine as well as Ayush, and whole lot of eye care organizations, blood banks, etc. So these are very robust international standards. We have presence in 13 countries like Philippines, SAARC countries, Afghanistan, Uzbekistan. These are countries which do not have their own standards. They count on us. Lots of interest from Muscat, Oman. In fact, this month we did 3 accreditations in Oman. So our standards are international level. They are very, very popular. And under certification, we very proudly released emergency department certification also. So total today, we touch about 17,000 hospitals, big and small, under various things. And each of them is mandatory to have a emergency department. So let's see the scope which is there for all. These are the strengths of accreditation. They are external objective evaluation. So the point here is that not many doctors today also are aware. So this is the request, and we are trying very hard at NBE and NMC level to have a mandatory 1 hour or 10-hour slot of about accreditation in this thing. So these are the strengths of accreditation: external objective evaluation, publishing of consensus standards, and they are very proactive, not reactive. So these are very systematic approach. So what exactly are these standards? There are n number of papers in public domain. As I believe Brigadier, he said that either you publish or you are part of the pub, something. I think Dr. Sagar mentioned that. So I totally agree with that. So there are n number of papers in which highlight the impact of accreditation in India. Over the past 18 years, a structure has been there, and very slowly that outcome-based, the value-based chain is coming into picture. So not only the provision of a healthcare, quality healthcare, but outcome, how does it monitor and benefit the system also is coming out. So lots of patient safety is the fulcrum, the linchpin around which the entire standards they revolve around. There are great number of professionals and organizations who are today subscribing. Whole lot of employment opportunities have been given because every department, every major department, hospital has a department of quality now, which links all these processes, and the entire effort is to proceed towards a process-based, system-based approach rather than a person-specific approach. So lots of papers are there, please search. These are the standards. All standards, unlike many other accreditation bodies, are free of charge. Please visit our website, nabh.co, www.nabh.co, and download these standards. Even if you do not feel the need, these standards are free. Free PDFs are available. Please download and see for yourself what exactly a standard looks, feels like, and what it means. So there are 25 and more such booklets which are there, and there's lots of wisdom in them. So coming back to NABH certification standards for emergency department in hospitals, they were released in 2016. So I think this was an idea which was ahead of its time. Government incentivizes quality. So like for every hospital which undertakes NABH accreditation or certification, they are entitled to 10 to 50% higher rate than ABPMJ or any other IRDA subscribed third-party insurance published rates also, which is a major impetus for all hospitals to undertake these accreditation. So these certification standards became very popular in a short domain. And I think since 2016, Dr. Praveen Agarwal, Dr. Bhoi, they all were active generators, active authors, and contribute. They formed this standard, which become very, very popular. We all realize, I'll not repeat everything because since morning we have been seeing the critical nature of all the emergency services, all the chaos which can result in an uncontrolled territory. But these certification standards were released in 2016 with a single aim to introduce quality, safety in the emergency services of any healthcare organizations. And they were to ultimately lead to a cost-effective, value-based, better outcome. So there were lots of benefits for the patient. Patients are the biggest beneficiary of any accreditation system. And these certification results in high quality of care because when we continue to do same thing again and again, habit forms. So that's not my principle, it's atomic habits actually. So there are benefits for the hospitals also. So traditionally since 2005, NABH has followed a 10-chapter approach. And each of these chapters addresses one particular area of the hospital. First is access and continuity of care. Second is care of patient. Third is medication management. Fifth is hospital infection control. Fourth is patient rights and responsibility. So first 5 chapters are always patient-centric. From entry of a patient to exit of a patient, whether it's a one-room clinic or it's a big multi-speciality hospital spread over acres and acres, the intent remains the same. And the next 5 chapters are related to management-centric, facility-centric. They take care of all the facility-based things. From firefighting to staff welfare, everything is addressed. There are lots of benefit for the staff because ultimately, not only their tangible benefits, but the intangible, indirect benefits are also addressed. These are the eligibility criteria that at least minimum of 25 operational bedded hospitals were required. It was more of an excellence standard it was drafted. And this is the matrix which we followed. So these are the chapters which I mentioned. They are the first 5, there were 9 chapters in emergency certification, but these chapters address the patient-centric areas and the management-centric areas. So why did this certification did not take off? Well, because I think the idea was today we touch about 17,000 hospitals and the certification has already crossed 12,000 hospitals, but there were very few takers beyond the government machinery. State of Gujarat was very proactive. They commissioned assessment of about 80 emergencies just before COVID. But then COVID really held us back. And today we are left with only 48 emergency department in hospitals over and above the NABH accreditation. So these are hospital-based emergency systems and number of emergency departments only 20. So total about 68 hospitals are applicant to this thing, which is a misnomer because the full accreditation also involves a very comprehensive checkup of the emergency department. But I think today that idea has come with the recent gazette notification happening, and now a very organized system of emergency medication starting to take shape over the years. I think we are ready to revise and relaunch the emergency certification or accreditation or excellence standard, if I call them, with all your active cooperation. That is the essential idea that I'm here today, and to invite all of you to form a committee, be an active part, give us that thing, and we will take it forward. And we assure you that these are going to be low cost. And one more thing which has happened at a policy level is that government has started to recognize quality in a much big way. They have made it mandatory for all AIMS, for example, to undertake. AIMS Delhi has already applied, sir is aware, right? The trauma center is an applicant. Out of 22 AIMS, 19 AIMS are today applicant for NABH accreditation processes. The Safdarjung Hospital, the biggest hospital in New Delhi, is already certified. RML Hospital is about to receive the certification. There are 10 more hospitals starting from ILBS to Janakpuri Super Speciality to Rajiv Gandhi Cancer, etc., etc. They are all Rajiv Gandhi multi-speciality. So they are all accredited and certified. So the state of Gujarat, for example, is fully compliant with all, even their PHC, CHC are today certified or accredited under the NABH standard. So there are lots of accountability at a public delivery level. So I think it's only natural that we undertake the revision as early as possible and relaunch these fantastic standards which have the potential to make a difference. So we are open to your suggestions, your advice, and your feedback also. Thank you so much.
Thank you, Dr. Pichar, for the excellent presentation on quality accreditation. Now we'll move on to the next one. That is from Dr. Srikanth, State Nodal Officer, Trauma Care, Kerala Emergency Rescue System. Over to you, Dr. Srikanth.
A very good afternoon, respected chairs, dignitaries. I'll just go through the emergency rescue system that is currently existent in the state of Kerala. We have just been having talks regarding the need for an emergency rescue system. Road injuries are still the leading cause of preventable injury deaths, accounting for about 40%. In India, it's still consistently being one among the 4 top leading causes of death between 10 and 44 years of age. Coming to the Kerala scenario, we have about more than 40,000 plus road traffic accidents happening every year and accounting for about more than 4,000 deaths per year. The 108 services started way back in 2010 in the district of capital city of Thiruvananthapuram and was extended to the district of Alappuzha in 2012. The then fleet had about 43 ALS ambulances. Initially, it was operated by 2 private agencies, and later on, the government agency KMSCL took over the operations until 2019. The present fleet of KEMS 108 was launched in the year 2019. KEMS is Kerala Ambulance Network for Injured Victims. KEMS means compassion in Malayalam. It is operated in an aggregator model and is managed by the KEMP, which is a wing of KMSCL. Now we have 315 BLS ambulances and a central control hub, which is operational at the Techno Park at Thiruvananthapuram. It has a capacity to call at least, handle at least 10,000 calls and 1,000 trips per day. The top photograph is that of the day of the launch of the KEMS 108 ambulances. The current operator is GVK EMRI, and the operator is responsible for appointing the employees, the cost of the ambulance, the setting up of the control room, the operational costs like fuel, salary, maintenance of the vehicles are all met by the operator. While KMSL pays a consolidated amount per ambulance per month according to the contract rate. There are 2 categories of ambulances that are operating. Of the 315 ambulances, 165 ambulances work around the clock, while the remaining 150 ambulances work during the peak hours of 8 a.m. to 8 p.m. Each ambulance has a emergency medical technologist. Let me correct my term. It's a technologist. And right now we have either GNM nurses or BSc graduates in nursing as with additional training in emergency medical procedures as our emergency medical technologists. These ambulances are now stationed in healthcare institutions very close to the black spots that have already been identified by the Road Safety Authority. And the average distance between the black spot and the station, or the base station, is around 2.9 kilometers. As an accident happens, somebody from the scene of accident gives a call to the trauma helpline 108, and the call is received at the hub, the control center, and the agent identifies a free or an available ambulance using GPS closest to the site of the scene of accident, and it is assigned, the vehicle is assigned to the particular incident. The ambulance reaches the site and the paramedic shifts the victim into the ambulance. A primary assessment is done, first aid if necessary is given, and the condition of the patient is informed to the control room, and the hospital to which the patient is being taken to is also informed. And then as the patient reaches the hospital and the patient is handed over to the ER, the case is closed and the ambulance becomes available for the next call. This is a view of the control room that is located in at the Techno Park. We have basic life-saving equipment in the ambulance along with rescue tools. Many a time our ambulance reaches much earlier than the police or the fire and rescue team. And we need to have extricate the victims from the crashed vehicles. So we have rescue tools as well as emergency medicines and consumables. all across the state, we have identified areas, or the areas have been defined, whether it is urban, rural, or difficult terrain, and response times have been fixed. We have 15 minutes for urban areas, 20 minutes for rural areas, and 30 minutes for areas with difficult terrain. Likewise, penalties have also been set up. So a vehicle down, no ambulance is supposed to remain idle for more than 1 hour per day. And according to the penalty clauses, penalties are imposed on the operator. All these ambulances being GPS enabled, we can have they can be lively tracked, as well as you can get a movement history from the server, which is situated in the control room, as well as there is a mirror server available at KEMS from which we can retrieve the data. Every detail is captured in the daily trip report, or the DTR. Right from the time the call is hit, you can get all the ingoing and outgoing calls, the vehicle start time, hospital scene reach time, the hospital reach time, and the time when the vehicle reaches back to the base, and the distance, the kilometers, the time taken to run. All these are captured in the DTR through a mobile app that is located in the ambulance. So if there is any undue delay in transport in any sector, then a query is raised, and if the explanation is unsatisfactory, penalties are imposed. KEMP, or the Kerala Emergency Medical Project, is the wing of KMSCL that is directly monitoring the operations. It is in control of the quality control of the vehicle, the equipment, as well as the services provided. It is also a grievance redressal body with a toll-free number, and generally the vehicle which is stationed in a particular district is supposed to run only within the district. So sometimes from the patient's side, there is a request to shift the patient to a medical college in a different district, or a higher center in a different district. So such calls are also taken by the KEMP authorities, and decisions are taken according to the merit of the case. Further monitoring, there is a district level committee headed by the district collector, and the DMO is the vice chairman. All the district chiefs of the various stakeholder departments are also members. So they meet once in every 3 months, and they are responsible for the quality control, and any recommendations regarding the change of the strategic location of the ambulances, or any change of category, or any policy change. Such recommendations are forwarded to a state level committee, which is headed by the Secretary to Department of Health as the chairman, and the Managing Director KMSCL as the nodal officer. All the state chiefs of the different departments are the members, and there are nominees from the operator side too. So they take decisions regarding any change of location, any change of category or policy changes, etc. These ambulances are very widely used during the Karipur airport disaster, which happened in 2020, as well as the Pettimudi landslide disaster in Idukki district, which happened in 2021. They were widely used. Apart from being used for COVID care extensively for the last 2 years, these are the challenges that we are facing now. I had a detailed discussion with the operator, the person in charge at the Technopark. So the primary issue we are facing is lack of vehicles for inter-facility transfer. So there are about 600 vehicles under the Director of Health Services, but majority of them, about 300 odd of them, are patient transport vehicles, and 34 of them are ALS ambulances. So many a time sick patients need to be referred to higher centers, and they are dependent on the 108 ambulances to refer the patients. So when such ambulances are utilized for interfacility transfer, then comes the second issue of non-availability of ambulance. Suppose there is an ambulance from a particular station is utilized for interfacility transfer, and actual emergency or a genuine emergency happens, a road traffic accident or a chest pain accident in the vicinity of that area, the 108 people find it difficult to supply an ambulance, so the ambulance has to be raised from another nearest base station, which is free. So the response time then increases. Then there is another problem. All the government under the DHS, the hospitals under DHS have specialist care only up to from 8 a.m. to 1 p.m. So any emergency that comes after 1 p.m., any trauma emergency especially, coming after 1 p.m., they are always referred to the concerned medical college. There is one government medical college per district. So usually they're taken to the concerned medical college. So there's we can see a long waiting line of ambulances waiting to hand over the patients to the ER personnel. So this is another problem that the operator is facing. The lack of adequate trauma centers in the state is another issue which is responsible for the long waiting time that we were just mentioning. Another thing is prank calls. The operator was saying that there was more than 50% of the calls that they receive are ineffective calls, either prank calls or missed calls or wrong numbers. And they have a policy to call back each and every number that has been made. And many a time they find that the children are making calls from their parents' mobiles. So they call their parents and they are warned to not to use allow the children to make such calls. Lack of public awareness. We had some previous speaker talking about that. What we find here is earlier people used to take the victims in any form of mode of transport that was available to them. But now that has changed. The awareness has increased. They are using only ambulances. So they call for ambulances. But as soon as the ambulance arrives and the door is opened, the onlookers or the first responders just carry just lift the patients and then just virtually thrown into the ambulances. So a proper shifting of the victim from the scene of accident into the ambulance is very rarely seen. Underutilization of 108 services is also noticed, especially in the districts where this has been introduced lately. To the northern part of the state, they have already been used to having a private or NGO network of ambulances. Even though the 108 service is free and the other services have a payment, they are still using the private ambulances for emergency rescue services, and 108 is used only for interfacility transfer. So these are the challenges that we are right now facing, and how to move forward. One is integration of ambulances from other sources, especially those under the DHS can be integrated into the 108 system so that more of 108 ambulances can be made available only for emergency rescue services. And likewise, other networks from NGOs who are operating ambulance services can be integrated into the 108 service. The KEMS is also planning to procure more ALS ambulances and neonatal ambulances for interfacility transfer. The government of Kerala is already upgrading in a phased manner all medical colleges and district and general hospitals into level 2 and level 3 centers, trauma care, providing comprehensive emergency care. So as soon as these become operational, they can be integrated into a system there, into the control hub, so that those patients who need not be transferred to medical colleges can be taken care of at level 2 and level 3 centers, thereby reducing the load at the medical colleges. Improving public awareness definitely will improve the situation, in informing them that all trauma patients need to be transferred in a proper way, shifted in a proper way, only in ambulances. And it is mandatory that they be handled by the trained healthcare professionals. Another thing is use of a mobile app for the layman. They have a mobile app in the ambulance for communication between the person, the driver and the control hub, but there need to be a app which the general public can use to make calls and communicate with the hub. This is what I would like to convey now. Thank you so much for this opportunity.
Thank you, Dr. Srikanth, for the nice presentation. We will move on to the next. We will have the discussion at the end. May I request Ms. Rikala VS to talk on IRAD? Ms. Rikala VS, please. She is a Senior Director in IT.
Good afternoon, dignitaries, faculties, and delegates. My name is Shrigala, Senior Director, IT from NIC, National Informatics Center, Government of India. My topic here is IDAR, that means Integrated Road Accident Database. All of us know the major concern of the society now is the accidents, road accidents, and the loss of life due to road accidents. In light of that, Ministry of Road Transport and Highways, Government of India have initiated a new application called IRAD. That IRAD is inaugurated by our Honorable Union Minister for Transport on 13th January 2020. IRAD is mainly using for collecting road accident databases, and this IRAD application is integrated with EDAR, another version of IRAD. This EDAR is mainly focused to get the timely claim and fast processing of accident victims, means disbursement of settlement of accident claims. Here in the IRAD, the major stakeholder or primary stakeholder is the police department. Police department on arriving the accident spot, they'll capture the accident details, and these accident details are fetched to the IRAD system. This IRAD system, then it have facility to communicate with the transport department, road owning agencies, and health services, ambulance services. These data will be as soon as the data is fetched into the system, there will be an alert to the transport people to find the mechanical defect of the vehicle, as well as road agencies will get an alert to investigate the road condition, poor road condition of the roads, and major part of the system is the health service. As soon as an accident victim arrives in the hospital, they can register in the IRAD system and treatment can be started. This system is seamlessly integrated with other stakeholders like LSA, Legal Service Authority of MACT, Metropolitan Courts, Child Welfare Committee, insurance companies. Everything is seamlessly integrated with IRAD through EDAR system. The data captured in the IRAD system will be flowed to the EDAR system, and the EDAR system can process the accident claims on a timely manner. This is the order of Honorable Supreme Court in the last 2022 to develop the EDAR system in continuation with IRAD system. This IRAD system is available in mobile platform as well as in the web platform. In the mobile platform, it is available in the Android-based and as well as iOS-based platform. The system has an easy and flexible user interface. Any layman who is having a bare knowledge of mobile operation can operate the system efficiently to capture the data. It is a GPS-enabled system. The accident coordinates, accident location coordinates will be captured in the system through the GPS availability in the system. The accident-prone area can be easily identified through the GPS location. This system has a role-based dashboard also. This dashboard will give the statistics of entire accident data in the country as well as in the state, in the district, in the taluk, each police station, easily identified through the dashboard by the higher authorities in the system. There are 21 reports are requesting by the MORTH to reduce the accidents and improve the road safety in the country. These 21 reports are available in the software, and other than state-specific reports also available. These reports can be utilized for further analytical purpose. IIT Madras is doing the analytical part, and using the data collected through the system, the analytical part is doing by the IIT Madras. This IRAD system is integrated with many other systems also. We have a database of vehicle registrations called Vahan system. Also, driver's details in the Sardi system, ambulance details in NHM system, then hospital details in the PMJY system. These applications are seamlessly integrated with the IRAD system, and whenever an accident occurred, the vehicle met with an accident will be fetched to a system by the police officer, and driver involved in that accident will be fetched. Any ambulance support is required, then it can be made available through the system. The patient registration can be done in the system through the hospital module available in the system. Then once an accident is registered by the police, one FIR will be registered. That FIR, this accident information will be flowed to the CCTNS system of police department, and the police department can generate an FIR based on the accident information of that reported case. For implementing this IRAD system, MORTH has provided many facilities, and they are providing each district hand-holding support personally is available, district rollout manager, and district rollout manager is reporting to state rollout manager. They'll report the state coordinator of NIC, and NIC is in turn reporting to a central NIC, Government of India and MORTH. This hand-holding support at any time, this support will be provided to the stakeholder department like police, these motor vehicles, transport, road earning agencies, and hospitals. As and when a training is required, each and every training will be handled by this support manpower provided by MORTH. These trainers will be well equipped with handling the modules very well. The feedback mechanism available in the IRAD software is considering to improve the system by incorporating the various feedback received from the stakeholders who are using the system, and thus the system is being improved in advance to utilize by the stakeholders in an efficient manner. The application support from the central level as well as state level is available in the system. Project monitoring units are available for the system to handle each and every queries of the stakeholder department. Each module have a well-defined workflow. For example, police department have a workflow defined for them. Motor vehicles have a workflow, and health also have a workflow. That workflow actually starts with a state admin, who is the nodal officer for the IRAD software. The state DHS or health secretary has identified one nodal officer as a state admin for health module. Then this state health admin decided the DHS has decided the district level admin also. This district level admin are the district monitoring officers for the IRAD health module. Then once this state admin and district admins are identified, then hospital registration is the next stage to the IRAD. Each and every hospitals in the state has to be registered in the IRAD system for utilizing the health module of the IRAD system. Once a hospital is registered into the system, the district admin will scrutinize the hospital and approve the hospital. After approval, the user who is going to use the system will be created, has been created, and these users will register or enter the accidents reported in that hospital. This is a screen of IRAD application, mobile application. Mobile application, actually, patient registration is the primary aim of the hospital. Patient registration can be in two ways. One accident, after an accident, a patient, accident victim can be directly taken to the hospital, and at that time, hospital authority will register his patient detail with the minimum primary information, like one accident is reported, this is the patient name maybe it is not mandatory, some information can be fetched. Otherwise, a police officer, a case from which the FIR is registered, that FIR registered case, the accident victim can be taken to the hospital. Here, John, one patient is available, is shown in this screen. Here, through the FIR registered case, this giving the FIR number, the patient detail will be fetched to the system, and the user of the hospital management can register the patient details in the health module of the system. Then each and every treatment stages and medical reports means digital form of medical reports can be uploaded in the system. There is a facility to updating the medical treatment details as well as the medical reports to the system. This will help to monitor the progress of treatment by the higher-ups of the IRAD system. Here, I have told that two types of victims can be admitted in the hospital. One directly admitting from the accident spot to the hospital. In that case, through this system, an accident intimation can be given to the police department. For that, one accident intimation, police intimation button will be there. Then this police intimation report, after receiving this intimation report, police will register the case, accident case, and the accident registration ID will be given back to the system. Otherwise, if the patient, accident victim is directly admitted in the hospital, then that patient wound certificate, discharge ceremony, drunk and driven certificate, etc. can be uploaded in the system and it can be utilized by the police department. Any fatal case is reported, then the postmortem report also can be uploaded. This will be made available to the police department for further closing that cases. Next one is from a hospital, the patient can be, or the accident victim can be transferred from one hospital to another hospital. There is a facility to shift that patient details from one hospital to another hospital. Maybe the accident may be reported to a minor hospital. From there, the full accident history can be transferred to the major hospital. Not only within state, from other state also, the accident can be transferred from, for example, Karnataka to Kerala or Kerala to Karnataka. These accident details can be. One advantage of the system is all the treatment history will be available in the system, and doctors can go further on the basis of the treatment history available in the IRAD system. This is one accident statistics since from January 2022 in Kerala. In this, one map is available, Kerala map. In this, different colors are available. This is the analytics part of the accident database, data collected in the database. Fatal cases can be easily identified, grievous injury can be identified, then accident-prone area can be easily identified, accident-prone vehicle can be identified, accident-prone age group can be easily identified. Many types of analytics are available in the IRAD system itself. This IRAD system is an additional health module. Health module is an additional requirement from the doctor side to feed the data at the time of accident reporting. This is not insisted through the doctors. Any support staff, a pharmacist or a nursing assistant can feed the system easily, and the system is designed such a way that anybody can operate the system very easily. This is all about IRAD.
Thank you. Thank you, madam. Now we invite Dr. Leonard J. Morris to give the memento to Brigadier Dr. Venkat Narayan.
So I think we may request all the speakers to come onto the dais. We will have a short session on discussion, like a very brief 3 or 4 questions can be discussed. My request, Dr. Venkata Narayanan, Dr. Vimal, Dr. Srikanth, Ms. Srikala, and Dr. Adul Mohan to come onto the stage. And 3 or 4 questions can be taken because we are running short of time. Please.
Any questions from the floor, please? Please mention to whom your question is addressed to.
Hello, I am Dr. Rajan. Question to Madam regarding the IT. IRAD is just now, yesterday it was installed at Palakkad. So we are worried about the manpower, but we can somehow manage. My question is, since it is being ended to a software, and that software is available for multiple departments. So regarding our patient data, it is becoming a public data. Yeah, so is the software having the legal consent to do this, when the patient's data is going outside?
Can you once more? Legally, it is.
Is it approved? Legally approved?
Yeah, patient data will not be becoming public data. It will be available to the police department only for further closing of the cases. the patient details will be available to the registered users of the hospitals only.
To the police department, actually, it needs only the wound certificate. But it will be available, all full data is available for the police department. Is it needed?
Yeah, it is approved by the High Court and Supreme Court. It is legally advisable to disclose the details to police department.
Ma'am, one question on IRAD again. I'm Dr. Manu, assistant professor from JIPMA Pondicherry.
I'm not hearing you.
I'm Dr. Manu, assistant professor from JIPMA Pondicherry, ma'am. Regarding IRAD, is this portal actually formed by IIT Madras and they have data access to whatever data is being entered? Because that is one part of the QI measures which they were telling, no, that data can be entered. So is the software development done by IIT Madras? Or?
No. Software is developed by NIC, National Informatics Center, Government of India. The data collected through the IRAD system will be given to IIT Madras, will be made available to IIT Madras only for analytical purpose, which is road condition, poor road condition, or how many vehicles are met with same make, or which is the age group that is being met with accident. Such type of analytics only doing by the IIT Madras.
Okay, ma'am, because it just in lines with what sir was actually asking, because we in hospitals, when they ask for MLC data, we have multiple hoop steps to actually make sure the data is really received, and we have not have any patient safety issues regarding data leakage. So this is ensured that IIT doesn't have any patient-specific data, only blinded data, right, ma'am?
Patient-specific?
Data, because are they shared patient identifier data for data analysis?
The patient details shared, or is there only the data is shared?
Only to IIT Madras.
Yes, sir. Yes,
IIT Madras patient details are not sharing. We are sharing the patient details to the hospitals only. Only the certificates required for concluding that case, means closing the case, certificates for postmortem report, drunk and driven report. Such reports only will be made available to the police department. These patient details will be available in the hospitals only.
Okay, thank you.
Hospital users, registered users of the hospital.
Thank you, ma'am.
Good evening, sir. I'm Dr. Vivek from Believers Medical College. My question is to Atul, sir. So for this NABH accreditation, does the institute have to apply for that, or once if they are registered, by default do they go for the accreditation?
I think that's a very good question. Accreditation as yet is voluntary, but government incentivizes that. So even for a public health facility, they have to apply. It's not mandatory. If it becomes mandatory, it becomes a regulation. So these are aspirational standards, slightly above the regulatory framework.
So, but on the contrary, if it is mandatory, so couldn't it help in improving the conditions overall?
Yeah, we would wish that. Of course, we would, that is too bad.
Yeah, we are already looking into this, and already a lot of discussions are happening with QCI and NABH with all the regulators, dental, nursing, allied, medical, homeopathy, and everybody to bring in accreditation standards. To call it accreditation or rating is a debate, but we're already on the pathway now. Yeah.
So I am Dr. Raju from Jubilee Thrissur. Sir, if a hospital is already been accredited with the NABH, is it necessary to have a separate accreditation for the emergency department?
No. So as of now, so these were certification standards, which meant that even if a hospital was not accredited, they could have their emergency department certified. So that because it's the first entry into the portal, right? As Dr. Vimal very rightly said. It's not the last point, it's the first point. But now we are thinking of relaunching them with active cooperation of the team as an excellence standard. So then it's not necessary either way.
I think we are running short of time. The CM will be coming soon, so we'll have further discussions during our coffee or lunch break. Thank you so much. Thank you.
request the chairperson to hand over the memento to Dr. Brigadier Venkat Narayan. Dr. Vimal Krishnan S. Atul Mohan Kochar. Dr. Atul Mohan Kochar. Ms. Srikala V.S. Dr. Srikant D. Now we invite Dr. Mohan and Kunwal to hand over the memento to our chairpersons, Dr. Lynette J. Morris, Dr. Jayakumar T.K., and Dr. Suma.
It's understood that the Honorable Chief Minister and Health Minister will be arriving here shortly. So we'll not start the next session as was planned earlier. So we'll get ready for the inaugural function. We'll have to wait for the distinguished guests to reach here. And the stage arrangements will have to start.
you can. You can.
I will introduce Ashik.
No. We should introduce the topic or the person. Introduce the person means.
They have already announced.
Okay. Yeah, but then. So now this topic is actually what it is.
Population emergency and trauma care, the healthcare and wellness center hospital.
If you can say something about that, you did it. I'll say something at the primary level.
I will tell something about Ashik.
And this is already going.
Done.
Yes. You can.
Hello.
Yes. Shall we start with the session? Over to you, sir.
Delegates,
Okay.
please come back to the main halls. The session is about to begin.
Ladies and gentlemen, good afternoon to you. May I start, sir?
You can. I just thought of introducing you.
Please.
He's a veteran army man. He's a mentor of for philanthropic and corporate social responsibility healthcare initiatives. He's a man thinking about work around. Welcome, sir.
Thank you, sir. So, ladies and gentlemen, over the course of the next 15 minutes or so, I'll be talking to you about population emergency and trauma care services. You've been hearing throughout the day the clinical aspect of it. You've been hearing about hospital systems, you've been hearing about trauma services. But what about the people? The people whom these have to serve. So what I'm going to try to present is the bottom of the pyramid, or actually the grassroots. This is what it's talking about. So the Tata Trust is among the many projects that it has got running. There is a project in Madhya Pradesh that currently we have got live, where with the government of Madhya Pradesh, we are working on strengthening the health and wellness center system, setting up model HWCs for the state government across 23 districts. So I'm part of that process, which is looking at this health system strengthening approach. So as you all are aware, this emergency care is a part of the service package that is to be provided by an HWC. We are all aware that this is the system that we have, but we conveniently tend to forget the community at the bottom of it all. We look at the tertiary care facility, we look at trauma centers, we look at all of that stuff, but we never look or consciously think about, as professionals, about the people who are involved in it. I'm not talking of just the healthcare workers, I'm talking about the people we are going to be serving. As on date, we've got nearly 1.5 lakh health and wellness centers, which, as you're all aware, is the first bricks and mortar point of contact with the government healthcare system. The ASHA is an accredited social health activist. She's not a government employee. The person sitting at this HWC is the first point of contact. So I'm looking at that and below. The package of services, as had been brought out by our earlier speakers, in these 12 service packages that are being provided, there is one very prominent one, emergency medical care and trauma services. This is a service package to be provided by a CHO. And if you look at the corner here, you find on the top the CHO, the A&M and the ASHA. The entire system of the health and wellness center focused approach is resting on these three ladies. I'm calling them ladies, but it could be anyone. A man, woman, doesn't make a difference, as long as they have the required qualifications. The CHO has been given the knowledge and the training. Now that has been given is an assumption that we have got, that they have been given the knowledge and the training. They have these beautifully developed modules and manuals. They have got training courses that have been structured. But what is their exact role? How many of us in the government system or in the healthcare system actually understand what the role of this one single person, CHO, Community Health Officer, who is a non-medical person in the system, who is looking at providing healthcare services? He or she has got a clinical role, has got a public health role, and has got a managerial role. Now, we all can just assume at what percentages or what proportion this is going to be. How much of it can a person who is not a part of the community provide to the community? How much trust will be there? These are the issues that come about. The problems faced by these health and wellness centers, the CHOs, there are perceptions and there is reality. What are the perceptions that we as a system have and what is the reality that these people face? They are the first point of contact, I'm again stressing, of the government healthcare system. Training and resources, are they enough? Community acceptance, is it there? Systemic expectations from you all that they will provide basic first responder care or basic care and then send them to your trauma care centers. Is it there? Do they have the capabilities? Trust in the healthcare system. How much of our out-of-pocket expenditure, as was spoken about earlier, is in the private healthcare system? How much are our people actually going to the government healthcare system? The spectrum of emergency care. All doctors know that emergency care is not, as was brought out, emergency medicine is a surgical specialty. At the level of a CHO who's not an MBBS doctor, how much can that person handle? These are the perceptions that are there, and the reality is something that studies reveal, our interactions with people reveal. But the elephant in the room actually is the problem faced by the CHO. One single person in an entire area who's providing clinical care to an extent faced by a large, potentially hostile clientele. How safe will that person feel in delivering this? We talk about violence against healthcare. There are many who would rather refer, say, send it away to the next higher facility rather than deal with it. That's the reality. So what are we going to do? One thing is, in public health, we all of us know what the problems are. But what are we going to do about the problems? That is the issue. So as healthcare professionals, we have to look at solutions. What solutions can we think of? Bharat at 100, 2047. What you see here is the Astana Declaration from 2018, and as Brigadier Venkat spoke about the vision. What is the vision for an India? An India where people everywhere receive emergency and trauma care that they need, where they need, and when they need it. So the point, ladies and gentlemen, is just this, simple and practical. When we look at this, the solutions that I'm trying to lay out, I'm not emphasizing on the problems at all because the problems are well documented, the challenges are known to everyone. So potential solutions which we are trying to bring about and introduce, it's all baby steps. We all know that the Ayushman Bharat scheme, the CHOs, the HWCs are a new cadre. It's a new concept. The pandemic came in between. It's evolving as we go along. So what we've got to look at is, we look at it from three prongs. We look at it from three different strata. We look at it as a systems approach. We look at it from the people's perspective, and we look at it from the point of view of technological innovations. All my preceding speakers have spoken about these in various extents, but looking and focused at the systems that you all have at the medical professional level. If you look at this vision, you look at the base of the pyramid is built of the people. We have got a community. Ideally, we need to have a community that feels empowered, a community that participates in the process of decision making, in the process of planning, a community that is health literate. How do we go about it? We need a health and wellness center, which is the first point of contact, which is patient-centered, which is going to provide appropriate care, which is accessible to people, and which is equitable. We use this word very loosely and freely, equitable. A patient transportation services, we spoke about in the past, the recent speakers have spoken about responsive ambulance systems, emergency care being provided through these services. All these now, what we are looking at from my perspective in the Madhya Pradesh project and in other health and wellness centers, you're looking at these bottom two, the base of the pyramid, so to say. The system approach, unless a district administration, a state government, in a previous presentation, it was asked about by Dr. Patanjali, about why wasn't a hospital taking action to adjust the beds that were required to be done? Local level action. The problem is the same everywhere. The action is always going to be local. It is required for the district level and downwards to work on solutions that they need for their particular district. Ultimately, it is the Gram Panchayat. Each village's problem, each rural area's problem is its own unique problem, but the solutions can be common. The capabilities, you need to have realistic expectations. You need to put a public disclaimer on what are the limitations that are there by a HWC, by a CHO. You need to have administrative endorsement of the actions being taken. You need to have possibly police protection being provided in case of an emergency situation. You need to provide liability insurance or legal protection for these CHOs. Empowerment of CHOs. We all are aware that perception management today is very important. Perception management doesn't mean just Facebook posts or social media posts. It is about approaching situations in a way that you're dealing with people. Ultimately, we are looking at people. Technical skilling, soft skills development. We need to have community resources being developed. Truly Panchayati Raj development, fostering, reinforcement. And we need to think about community emergency responders. There's been a lot of talk by the earlier speakers about we need to identify responders, we need to train them, we need to find equipment for them. But how are we going to do it? That cannot be done by a central diktat coming from Delhi. It has to be done at the local level. It has to be done by initiatives being taken at the local level based on standard templates that can be issued. Focusing on the community. If we don't focus on the people we are serving, we will develop skewed approaches. We will develop approaches that may not meet the needs and aspirations of people. So people need to be empowered suitably. You look at community gatekeepers, we are looking at active involvement of the Gram Panchayat. Active involvement is the key word. You look at schools. One of our colleagues just spoke about schools, that they would teach 8,000 children, 10,000 children. You are looking at a network effect. You're looking at focusing on school teachers, not directly teaching the school children. I'm recommending and suggesting that school teachers be focused on to act as a resource for you. Train the trainers. You look at public relations. Unless the system, the administration of the district, the Zilla Parishad, the Gram Panchayat all starts focusing on people, it's not about votes. It's about building a positive feeling towards the healthcare system. Trust in the healthcare system. Everything devolves down to trust. When we obtained feedback from our district consultants to talk to the CHOs, to find out what is it they perceived, they all uniformly gave this thing that people lack trust in the healthcare system. They say, we are referred to the government hospital at so-and-so place, wahan hame koi dekhta nahi. That means no one is looking at us when we go there. What's the point in us going there? We'll go and spend money going somewhere else. So trust in the healthcare system cannot be done by the peripheral level. It has to be from the central level, from the state level, percolating down. Role of technology. The easiest thing to do is say artificial intelligence, robotics, drones. But in healthcare, the feeling of the man on the ground is he wants a warm body. He wants someone to speak to him. He wants someone to hold his hand. He wants someone to be able to converse with him. So we cannot replace a human being, in my feeling, in the next at least 20 to 50 years by just using artificial intelligence. That's fine. We can harness for data analytics, but feet on the ground. In the military, we use this terminology that unless you hold ground, unless there are people on ground, you can have all the fancy systems that you have. The Americans couldn't hold Vietnam. They couldn't hold Iraq. They couldn't hold Afghanistan, but they bombed everything out of them. Technology is not a replacement for people. You can look at patient transportation. Why can't we use a model like Uber, which is automatically allotting based on availability? We should not be having a human interface there. Nearest, geographically proximate ambulance vehicle distribution, electronically communicated transportation location devices, telemedicine. Telemedicine is not just for the patients. Telemedicine can include consultation on professional matters by the CHO in an emergency. Should be able to call up a central technical helpline ki ye ho gaya, what do I do? Now that is a simple thing. That is telemedicine, using a telephone to obtain medical information. Standalone clinical decision support systems, nothing fancy, simple algorithms available maybe in a PDF form or an image form on your phone or on a display chart. You look at simple solutions will always work. The more complicated, the more technology driven, the less likely it is to work. You need to think of logistics and supply chain management. What about consumables? Why can't that be in a push model? Why doesn't CHO have to indent? How does Lulu hypermarket, for example, how do they stock their cupboards? How do they stock their shelves? Do they go manually counting everything and raising an indent? Everything is in a push mode. Some stock depletes, straight away it's rushed in there. That's how they make money. But we in the government are not looking at money. You're looking at service provision. So push models can be looked at. Ultimately, ladies and gentlemen, what we have to look at is, in a healthcare system, you have to adapt, you have to adjust whatever you're doing at the peripheral level, you have to improvise. Improvise has been given a very bad word. We call it jugaad in India. Very bad. We should not be doing jugaad. Improvise means dealing with what the situation is at that point in time with whatever is required. It is not about jugaad. And the last is ultimately, irrespective of the challenges that we are faced with, we have to overcome. Now, on a side note, that little hill you see there, that pointy thing, that is Tiger Hill. You see the vertical, almost vertical nature of it. That is the hill our soldiers fought and got back. Now, that is a seemingly impossible task. Healthcare is like this. It seems impossible to deliver, but eventually we will get there. It just requires concerted effort, teamwork between people planning trauma care centers, trauma services, and linkages with the people, the grassroots level people, and the healthcare workers that we have. I have finished, sir. Thank you.
Colonel Cariappa, you have well brought out the grassroots work that should be done, and you have also excellently shown that man cannot be replaced by a machine. And I think that is a take-home message. And if there are any questions, you can raise it now.
CMR, we are the apex funding body for health and biomedical research in India. Now, emergency departments, as you all know, they cater to a wide range of acute conditions arising because of complications with non-communicable diseases, communicable diseases, injuries, pregnancies, with non-communicable diseases contributing the most of the chunk of the patient population there. And almost half of this, almost 50% of this burden can be reduced by improving emergency care systems and pre-hospital care system in India. Also, at present, the ECS system is rather fragmented. And since the adoption of principles such as Sustainable Development Goal in 2015, there is more emphasis on now developing healthcare delivery systems with an integrated approach. Now, what is the need for emergency research in ECS in India? Currently, most of the research in ECS is coming from Western countries, and obviously problems in lower middle income countries like India's are not being identified. So country-specific research gaps need to be addressed to promote regionally relevant research that will enable policymakers and planners to make efficiently informed decisions about research allocation and program assessment. Research is also required to identify strategies for enhancing functions of emergency care systems and to optimize prevention and treatment of conditions that present in the emergency departments. Now, there has been a shift of kind of researches that ICMR is going to fund and is focusing on. One call for proposals is presently open with the deadline of 28th April. And now we are looking at projects that are following these 4 Ds. The first kind of research we'll be supporting is the discovery research that is aimed at finding novel interventions for basic research Example of this can be preclinical and phase 1 studies. Developmental research that is aimed at developing interventions for screening, diagnosis, prevention, and treatment conditions, making these more efficacious or affordable. The third point is what we are concentrating most at the present, delivery research or implementation research. This is aimed at learning how to overcome the barriers in delivering effective interventions. It will include health system-based interventions to increase access and to successfully implement national health programs or schemes that help in reducing inequity and improving the quality of healthcare. Descriptive research is what goes on most in India, where we try to understand the disease condition, its burden, but this is having the least weightage of the 4Ds. These kind of researches will be funded by ICMR only if it is deemed by the organization that it will be helping in finding the solutions. For emergency care systems, we are focusing more on implementation research, intervention research, and research with system thinking approach, where we try to understand what ECS is, how it functions, and design and implement, evaluate interventions that help in improving access and affordability. Now at present, in the last year, based on priorities of current and future needs, we have funded the kind of research that were answering the question how to save lives and how to improve treatment outcomes. In the coming sessions, we are going to fund research that answers questions that are pertinent to India, conditions or problems that are common in India or unique only to India. Now, what is being expected from research projects? We are trying to fund those kind of studies that find solutions that can be readily implemented. Also, we look at the investigators' profile, how much commitment they are having just in sharing the data. Merely generating a publication out of a study is not the goal here. Also, research that is going to have some kind of a positive benefit for the patient and public overall. Now, implementation research as a concept is somewhat new for India. It is very commonly performed by WHO in large system studies, but this is something new that we have adopted from last year. In implementation research, we take the proven mechanisms that can be implemented easily and widely. The project or the concept should be easily scalable and have a holistic approach. One good example of this can be the clinical trials or where maybe in one of the larger tertiary care centers, the clinical trial has been performed in an urban center, but these centers can then provide handholding to maybe to a center in a lower tiered city. Also, one very important aspect that ICMR looks for before funding any study is how much is the translational value of that study. Translational value implying that the project must have some outcome that helps the public or the policy of the country. In Indian context, we are looking at concepts and studies that are having some cost-effective outcomes. They are maybe indigenized or having Indianized versions of technique that take into account the geographical variations of our country, that optimize prevention and treatment of conditions presenting in the emergency care systems, and again, which align with the national program and priority. Now, research with potential to improve various aspects of practice. Projects that will attempt to establish uniform standard of care. Projects that will help in improving survival and leveraging technology to improve survival. Improving post-treatment quality of life. Reducing the burden of patients with advanced diseases. We can also look at quality improvement and capacity enhancement research. We expect from the research institutes, again, to have collaborative and multicentric mechanisms. We look at their commitment to share the data generated. It should not be that the group is working in silos. The gold standard for research should be maintained. This is something that ICMR very commonly observes, that research projects that are coming to us are not up to the mark. So if there are people from academia, from students, then I'd like to request them to please get involved in some kind of research capacity building workshops, because we have to enhance the quality of research work that we are generating. And also the organizations or the group of investigators that is involved in the study should be not for profit. ICMR does not fund for profit organizations. Okay. Yeah. Okay. Yeah. Now, common challenges in emergency systems researches, there is usually a lack of environment to conduct research. There is limitation of research infrastructure and trained human resources, scarcity of reliable data, paucity of clinical trials, limitations of time and funding, and lack of research aptitude. So we've had one brainstorming session in ICMR around 18 months back, where we have found and shortlisted some areas of focus based on the inputs that we've received from EC experts countrywide. These are only some suggestions. It is not limited to this, but at times people just happen to ask us directly, okay, we want to put in our research, and they expect us to provide them a direct topic. So I have shortlisted a few topics here. For emergency systems, we can look at the research questions such as which components of emergency care system have the greatest impact, which mechanisms most effectively expand access to critical care, initiatives to improve knowledge and skill of healthcare workers and layperson about emergency care, then what is the best way to reduce harms of overcrowding, that is more patient, then there is spaces to see them in the emergency department. Now, the area in ICMR is not merely limited to emergency. The division under non-communicable diseases, we have a specific called as the trauma, emergencies, and burns, aligning with the National Program of India. So maybe even the burn cases that come to the ED, if there are any area experts who are working in the area of burns, you can look at conditions such as protocolization of burns, then the research component of skin banks, devising a predictive scoring system for acute burn patient, development of training programs in management of burns as per the Indian scenario. Other areas such as drowning and maybe multidisciplinary research can also be considered. Multidisciplinary system research is something I'd like to bring your attention to. We need to develop more projects that concentrate on pain-free burns and trauma wards, about studies that explore conditions such as lead time to start of definitive care in trauma patients with multidisciplinary requirements, studies that look at issues such as delivery of anesthesia on arrival for trauma management, and how we are treating the polytrauma cases in critical care. Then also we have considered the possibility of coming up with a National Resource Center for capacity building and research in trauma systems. I would like to request the tertiary centers and other institutes to maybe take an initiative in this direction. We are considering projects that involve looking at development of 3D virtual immersive simulation, development of AI-based platform, and development and implementation of pre-hospital notification system. Then RTA is something, road traffic accident or road traffic injury is something that has been explored a lot. There is ample amount of literature in the area available from India. But again, it is one of the conditions that present in maximum numbers in the emergency departments. Other areas that can be explored from ED perspective, and this can be more helpful for junior level faculties and maybe residents who are trying to develop some kind of research in this area. So you can look at conditions such as traumatic brain injuries, sports injuries, oral and maxillofacial injuries, occupational injuries, poisoning, but poisoning from the angle of animal attacks and like snake bites, falls, new treatment modalities, research in ED focusing on special groups such as geriatrics, pediatrics, clinical guidelines and standard treatment protocols for conditions that are yet unexplored, or if you want to suggest some kind of improvement in the ED protocols. Now, the last three that are enumerated here, there is again a dearth of literature from India. Firearm injury, researches on violence, assault, and abuse cases. Then researches on natural calamity, mass casualties, and expressway injuries. These are for any junior level faculties or students here. These are the two publications that I like to highlight. Kindly go through these, and you can note them down and go through these, and it will give you a very clear picture of how to come up with relevant research question if at all you are planning to go for research in emergency medicine. While submitting a project to ICMR, once you have submitted the project, there are a couple of further steps. It will be once technically evaluated, then there will be administrative approval and financial concurrence, and then ultimately you will be granted a sanction. So please note down that there are a few steps, and it takes almost a year's time from application to get the funding from ICMR. And in conclusion, any kind of research activities, now the clinical environment is quite happening, but research is dry, comparatively a drier field. And obviously conducting it, it requires a lot of paperwork and a very different kind of focus. Any kind of success with the research endeavors is possible only with all kind of concerned stakeholders joining their efforts. That is it from my side. Thank you.
Dr. Stuti, that was a very comprehensive talk on research, and we know that research offers credible, reproducible data which will be of use in later stages as well. And then you have already given the guidelines as to how it should be conducted. And maybe owing to paucity of time, because we are in the process of the inaugural function. So maybe we'll hold the discussion at a later date. Thank you.
Excuse me, delegates sitting behind, please come and occupy the front seats for the inauguration function.
our Honorable Health Minister, Srimati Veena George Madam, and all the other distinguished guests. Tinku Biswal Madam, our Principal Secretary, Health and Family Welfare is here. And the inaugural function will start as soon as the CM arrives. We will make it a brief function for the very reason that the Honorable Health Minister and the Chief Minister have to attend another function, which is about 10 kilometers away from here. But however, within the limited time available, the Honorable Health Minister has requested for a roundtable, desires to have a roundtable meet with the key stakeholders who are here, all the distinguished delegates, the WHO representative from Niti Aayog, from NABH, and our chairman of the PG Medical Board, Vijay Osa sir, for a brief meeting. Madam would like to have a roundtable meeting, which is arranged in one floor above. So we'll make the inaugural function very brief, and we are waiting for the Honorable Chief Minister to arrive. Thank you. I'm sorry. There's a slight delay in the to start the inaugural session. So meantime, I request we will have the roundtable meeting, and by the time the CM is starting, we will come back to this hall for inauguration. I request that Madam distinguished guest, please go to the.
Now we shall be having the memento and certificate distribution for the speakers of session 4. I invite Dr. Bindu Mohan to give the certificate and memento to Colonel Dr. MP Kariappa. I invite Dr. MP Kariappa onto the stage. Now I invite Dr. Stuti Sarath Bhargava onto the stage to receive the memento and certificate from Dr. Bindu Mohan. Thank you.
A very warm good evening, dear ladies and gentlemen, and welcome to Kerala Emergency Medicine Summit 2023, the first ever international summit on strengthening integrated emergency and trauma care services. The emergency departments in Kerala has been widely recognized for its intelligence, excellence due in large part to the strong support provided by the Kerala government. The state government has made significant investments in emergency healthcare, infrastructure and technology, including the establishment of well-equipped emergency rooms and ambulance services. Additionally, the government has implemented various training programs for healthcare professionals to ensure that they are well prepared to handle emergency situations. This level of support has enabled the emergency department to provide prompt and high-quality care to patients in critical condition. As a result, Kerala's emergency department has become a model for other states to follow in terms of efficient and effective emergency health care. This is the first of its kind emergency medicine international conference being conducted in the state. So ladies and gentlemen, once again I would like to welcome all the dignitaries on the dais with a huge round of applause. So to start this occasion, let's praise to the Lord Almighty. For the prayer, I would like to welcome Anu and Shazna onto the dais.
Satgurudeva Sachidananda Tava Pada Kamalam Sharanam Satgurudeva Sachidananda Tava Pada Kamalam Sharanam Jivadayaka Hridayeshwaranin Sannidhi Matrame Asrayam Prabhu Jivadayaka Hridayeshwaranin Sannidhi Matrame Asrayam Prabhu Satgurudeva Sachidananda Tava Pada Kamalam Sharanam Satgurudeva Sachidananda Tava Pada Kamalam Sharanam Tava Pada Kamalam Sharanam.
Thank you so much, everyone. For the welcome address, I would like to welcome Srimati Tinku Biswal IAS, Principal Secretary, Health and Welfare, Family Welfare, onto the dais.
Honorable Chief Minister Shri Pinarayi Vijayan, Honorable Minister for Health and Family Welfare, Srimati Veena George, other dignitaries on the dais, ladies and gentlemen. It gives me great pleasure to be here with all of you and to welcome you all to this, the first summit, the International Summit on Emergency and Integrated Trauma Care. As we were having a discussion just prior to the Honorable Chief Minister coming here about the need for Kerala and the rest of the country to be focusing on integrated emergency and trauma care, especially in the Kerala context, while we have achieved marvelously in terms of many of our health indicators, there is obviously a lot of room for improvement. And one of the focus areas for the state government is to improve its capacities as far as trauma care goes, emergency and trauma care. Many of the delegates have visited the Trivandrum Emergency and Integrated Trauma Care Center that we have. But it is not merely about the infrastructure that we put in place, it is also about the processes and the capacities, the human resources, as well as the other resources that we need to train and have in place, which is exactly what we were discussing in terms of a pool of trained resources, which would take us through and see us through, and also protocols in responding at every level, prior, preclinical, and after the case reaches the hospital. So it is in this regard that we have with us a large delegation of experts, both national and international, and we are very, very pleased to have you all over here. It is because of this commitment that we also have the Honorable Chief Minister here with us today to reflect the commitment that the state has in improving these indicators. I would like to take this opportunity to welcome Srimati Veena George, Honorable Minister for Health Women and Child Development, Government of Kerala, who will be chairing the session today. Welcome you, ma'am. The Honorable Chief Minister has taken his precious time off. As you are well aware, during a situation where the Chief Minister's schedule is packed and there are emergencies coming up, he had agreed to be here earlier. And however, there was an emergency situation which held him back, which was very unlike because he's very, very punctual and on the dot. So we are always, when we come, we ensure that we are there at least half an hour in advance because you don't know when he will arrive. Thank you so much, sir, for coming here and joining us because this makes a huge difference to this gathering today. I welcome you, sir, on behalf of the Department of Health and all of the delegates present here. We have with us the Acting Representative and Deputy Head, WHO India, Ms. Payden, who has been associated with us for quite some time with the state. She was here recently for the G20 Global Summit. I thank you, Ms. Payden, for coming here. I welcome you warmly to this meeting. I have on board over here with us several dignitaries, Dr. Thomas Matthew, the Director of Medical Education, Dr. Mohan Kunumamal, Vice Chancellor, Kerala Health University, Dr. Ajay Kumar, Dr. B. Abdul Rashid, Dr. Kala Keshavan, Mr. Srinivas from Healthcare Tata Trust, and of course, Dr. Vishwanathan, the man behind this summit. I welcome them all on behalf of the Department of Health and Family Welfare and the delegates present here. It is a privilege for us to have all the special delegates who have come, national and international experts, to help us in improving our processes, to have this discussion. And this is not, it's a one-of-a-kind workshop in the sense that it creates a start and a beginning at a time when Government of India is also pushing for strengthening emergency and trauma care. I welcome you all to this meet. There are delegates who are participating in this meeting, and we have a lot of students with us. We have a lot of faculty and doctors from both the Department of Health Services and the Department of Medical Education who are present here. I welcome you all, the media, and every other person who is present here. Let me take this opportunity to welcome you all and hope that you take the best out of this summit with you. Thank you very much.
Thank you so much, ma'am. Moving on the inaugural ceremony for lighting the lamp, I would like to welcome Honorable Chief Minister, Government of Kerala, Shri Pinarayi Vijayan. So ladies and gentlemen, let's give a huge round of applause for the inaugural ceremony of Kerala Emergency Medicine Summit 2023. Also, I would like to welcome Srimati Veena George, Honorable Minister for Health and Women and Child Development, Government of Kerala, along with all other dignitaries on the dais. Thank you so much, everyone. And it's time for the inaugural address. For that, I would like to welcome Honorable Chief Minister, Government of Kerala, Shri Pinarayi Vijayan.
Distinguished guests and friends, greetings to you all. Kerala is privileged to host the first international summit on integrated emergency and trauma care. Emergency medicine is an emerging field of healthcare as far as India is concerned. And as for Kerala, we have made seminal contributions to several sectors, including healthcare. Kerala is widely acclaimed around the world for its achievements in the health sector. Our life expectancy, infant mortality, maternal mortality, and so on are at par with developed nations. It is our people-centric public health system that has laid the foundation for all these achievements. Of late, we have set new standards in dealing with outbreaks of diseases like Nipah and even pandemics like COVID-19. Our robust public health systems have played a pivotal role in effectively handling such emerging health concerns. So as to further strengthen it, we are implementing the Ardhram mission. We are making our public health institutions people-friendly, upgrading the infrastructure in them, transforming our primary health centers to family health centers, providing super specialty services even in taluk and district hospitals, promoting research in biotechnology, virology, genomics, etc. We are increasing our capacities to tackle lifestyle diseases and preparing strategies for the same. Amidst all this, we are also seized of the need to provide quality and time-bound emergency and trauma care to our citizens. It is because the government of Kerala is committed to the same that we have prepared a Kerala trauma care policy in the light of the National Medical Mission's guidelines. As part of the trauma care policy, advanced trauma care facilities are being set up in government medical colleges, district and taluk hospitals, and major private medical care institutions. A number of relief programs, including meeting the initial treatment expenses of the accident victims by the government itself, are under consideration. Emergency medical assistance would be ensured to each accident victim without charging money from them for the first 48 hours of their hospital admission. Kerala has already started emergency medicine departments in the government medical colleges in Kozhikode and Thiruvananthapuram. 106 posts have been created in the government medical college Thiruvananthapuram alone for emergency medicine and trauma care. Adequate posts are being created in all the medical colleges in the state for emergency medicine departments. We have also improved the infrastructure and equipment across all these institutions so as to deliver the best care for needy patients in accordance with the Kerala Trauma Policy document. Care with sustainable quality is the Government of Kerala's vision, and the Emergency Medicine Department in the Government Medical College Thiruvananthapuram is being developed as a model with state-of-the-art facilities and infrastructure. Many of our institutions are in the process of obtaining quality accreditation through national agencies. Capacity building measures in terms of equipment, infrastructure, and manpower are being augmented as per the needs so that quality of care is ensured. An independent committee has been created under the Department of Health to assess the gaps and to suggest solutions for providing optional care. As part of implementing the Kerala trauma policy, geospatial localization of trauma was conducted across the state. Also, around 315 ambulances are being parked at identified black spots across the state and are being operated through a centralized system located inside the Technopark campus in Thiruvananthapuram as part of implementation of the policy. An ambulance tracking system is being implemented in the Government Medical College Thiruvananthapuram as well. In the emergency services, we have taken steps to ensure that structured EM department with a proper triage system are functional in all our medical colleges, and priority treatment based on the requirement is being provided through the division of treatment zones into red, yellow, and green. We are also planning to implement a strict referral and back referral policy to avoid crowding of facilities. In accordance with the Kerala trauma policy, training is being given utmost priority. The Government of Kerala's commitment to ensure the best trauma care in the country is evident in the fact that we have been at the forefront of starting the Apex Trauma and Emergency Learning Center sponsored by Tata Trust in a 25,000 square feet area with state-of-art facilities including simulation labs and training of all categories of healthcare professionals. This facility was conceived in 2018 and inaugurated in 2021 for providing 5 department courses in handling emergencies and trauma. The scope of this training center can further be expanded based on the requirements in the field of simulation and advanced training. An additional area of 25,000 square feet has been earmarked for this, that is, training in minimal access procedures. We are aiming to bring world-class emergency medicine departments to all the medical colleges across Kerala. It is with that view that this summit has been organized. This summit will facilitate the interaction between various stakeholders, including the World Health Organization, Government of India and the Government of Kerala, Tata Trust, AIMS, and emergency medicine departments inside and outside the state. Through this summit, we hope to provide a platform for discussion on various perspectives of integrated trauma and emergency care, standardization of training for faculty and students, pre-hospital care, initiation of trauma, stroke and cardiac registries. I am sure that this summit will turn out to be an excellent opportunity for evolving policies and guidelines and taking this relatively new concept of emergency medicine forward. I wish this summit all success and declare the first international summit on integrated emergency and trauma care inaugurated. Thank you.
Thank you so much, sir. We have a small token of love and appreciation for your valuable presence. And to do the honors, I would like to welcome the Vice Chancellor, Kerala University of Health Sciences, Dr. Mohanan Kunnumal, onto the dais. Ladies and gentlemen, let's have a huge round of applause. So let's move on to the presidential address. For that, I would like to welcome Srimati Veena George, Honorable Minister for Health and Women and Child Development, Government of Kerala.
Thank you. Good evening, all.
Honorable Chief Minister Sri Pinarayi Vijayan, Ms. Patent Representative and Acting Head, World Health Organization, Srimati Tinku Biswal, Principal Secretary Health, Government of Kerala, and other honorable dignitaries on the dais and speakers and participants in the conclave. First of all, I would like to say that this event really marks the beginning of a new era in emergency and trauma care in the country and reiterates the commitment of state government to provide state-of-the-art health care to its citizens. As Just Honorable CM has told us, emergency medical care is an important focal area of the Department of Health, Government of Kerala. Whatever may be the type of emergency, the aim of all the system is to give quality care in minimum time. Emergency care has multiple factors, including accessibility to facilities, availability of transportation facilities like ambulances, pre-hospitalization care, handling of patients at hospitals, and skilled and dedicated human resources. Kerala is and has been at the forefront of public health care in the country and is at par with even developed nations. We have set standards for others in handling disasters and pandemics. CM has mentioned about the low infant mortality rate, maternal mortality rate, and also the higher level of life expectancy. We have been lauded for the way we handled Nipah, COVID, and the floods that devastated the state a few years back, and the COVID challenge is not yet over. The Advanced Trauma Care and Emergency Learning Center, ACHALK, set up with the support of Tata Trust, is designed to fill the gaps, especially in training and skills in emergency and trauma care. The state has taken steps to strengthen emergency departments in healthcare institutions across the state. Medical colleges play a pivotal role in emergency care, and many of the steps to strengthen the emergency clinical care at hospitals have already been initiated. We just had a discussion before this meeting, and we were discussing about the system we have adopted in the state, and during this year, in 22-23, we have developed an SOP for emergency medical care in the state. It includes some 50 components. We took more than 40 hours to develop that SOP, and that is, we took the pilot project, we implemented the pilot project in Thiruvananthapuram Medical College, and that is a model project, and we are planning to implement this in every other medical college. The government is taking steps towards setting up emergency care departments in all medical colleges. The trauma care system under the government has been restructured and strengthened based on the gap analysis undertaken by the state. And based on the study, state has taken steps to identify the following: identification of hotspots, strengthening of emergency response system and transport, including ambulance services, upgradation of infrastructure and equipment in the emergency department, capacity building and training of manpower, strengthening of manpower. CM has told already, we have identified more than 350 hotspots across the state, and basic life support ambulances are stationed in the hospitals along the state and national highways closer to the hospitals for effective emergency response and rescue operations. These hospitals were also strengthened and upgraded to deal with trauma and emergencies. These hospitals were also linked in a hub and spoke model with nearby medical colleges to ensure specialty care. It's also observed that the victims of trauma are stabilized and referred to appropriate higher centers which are within 30 kilometers radius of the first-line centers. All casualty services were renamed as trauma and emergency care with the implementation of triage model in all the centers. Patients are categorized as red, yellow, and green based on the severity of the injury for stabilization and appropriate treatment and reference. And it's already mentioned here, Kerala has started emergency medicine departments at Kozhikode Medical College and Thiruvananthapuram Medical College. So this conclave, I think, is a step towards bringing world-class emergency departments in all medical colleges across Kerala. Many institutions have first started the process of obtaining national accreditation and also international accreditations. Capacity building measures in terms of equipment, infrastructure, and manpower are being augmented as per the needs so that the quality of care is ensured. An independent committee, as mentioned by Honorable CM, has been created under the Department of Health to access the gaps and to suggest solutions for providing the optimal care. It was this committee who sat for more than 40 hours and we developed that standard operating procedure. In the emergency services, a triage system has been implemented in all medical colleges and priority treatment based on the requirement is being provided through the division of treatments in different like red, yellow, and green. So I would like to thank all the dignitaries who have admitted our invitation and who have come over from different parts of the world to join this conclave to make this a fruitful one. And the government wishes all the very best to this conclave and hopes that a document reflecting the deliberations here would be submitted for consideration. Once again, I thank you all for extending an invitation to the event. Thank you very much. Thank you. Thank you so much, ma'am. A small token of love and appreciation for our Honorable Minister for Health and Women and Child Development, Government of Kerala, Srimati Veena George. To do the honors, I would like to welcome Dr. Thomas Matthew, Director of Medical Education, Kerala, please. Thank you so much, ma'am, for being with us. Your presence made us so proud. So moving on to the special address on this dais, for that I would like to welcome Ms. Payton, Acting Representative and Deputy Head, WHO India.
Honorable Chief Minister, Government of Kerala, Honorable Minister for Health and Family Welfare, esteemed dignitaries on the dais, international and national experts, academicians, representatives from ICMR, DGHS, Ministry of Health and Family Welfare, New Delhi, Niti Aayog, AIMS institutes, partners, and others. Ladies and gentlemen, a very good evening to you all. It is indeed a privilege and honor for me to speak at this august event in God's own land. I thank the organizer for inviting us, WHO, to this very important event. I applaud Government of Kerala for organizing this very crucial and timely summit. In India, injuries kill more than 3.75 lakh people annually, of which 1,40,000 deaths are from road traffic injuries. To put this in perspective, around 1,032 people would die from injuries in the next 24 hours. Of this, over 360 deaths would be from road traffic injuries. Many of these lives could be saved by building a strong emergency care system, which provides an integrated platform for delivering equitable, accessible, quality, and time-sensitive healthcare services for acute illness and injury across the life course. Globally, particularly in low-resource settings, the emergency care system suffers from fragmentation of services from the pre-hospital care to facility-based care. It was in this context that the 72nd World Health Assembly on 28 May 2019 adopted World Health Assembly Resolution 72.16, which was referred to earlier today, calling efforts globally to strengthen the provision of emergency care as part of universal health coverage. Now, for WHO, one of the mandates is to improve integrated service delivery to ensure no one is left behind. WHO has published a range of guidance documents to guide policymakers, planners, administrators to develop customized action plans suited to their national and local contexts, along with resources for training and standards for essential emergency care services and resources for each level of the health system. And we are really happy to see that many of you have used those resources for developing training modules, adapted them at the national level as well as at the state level to carry out many trainings. Now, beginning the 11th five-year plan, India has accelerated efforts to improve health system preparedness to respond to injuries. These efforts have shaped the national program for prevention and management of trauma and burn injuries. I congratulate the Government of India for taking the historic step of developing a comprehensive strategic plan for injury prevention to address the most common types of injuries. We also heard various initiatives that have been taken by different agencies like experts from AIMS, Niti Aayog, and others have also shared the initiatives that have been taken to address emergencies and injuries. I'm delighted to note that since the launch of the State Action Plan for Trauma Care in 2016, Government of Kerala has taken systematic efforts in strengthening emergency care response system, including the upgradation of 25 hospitals to level 3 emergency care facility, 9 hospitals to level 2, and 2 hospitals to level 1 or Apex emergency care facility. This morning, we visited the level 1 integrated emergency care facility in Government Medical College, and we were really impressed to see the amazing work that has been done there. We also had the opportunity to visit the Apex Trauma and Emergency Care Learning Center, which has very excellent facilities where over 7,200 doctors, nurses, and nursing assistants have been trained in emergency care over the past 3 years, which is really commendable. Integrated emergency care services have been developed by the state, and this will really pave the way for building replicable models for adoption and scaling up both within the country and beyond. I look forward to transformative ideas and informed deliberations emerging out of this summit, which will really help us shape a goal of building a resourced, dynamic, and integrated emergency care system at the national, state, district, and as well as at the block and village level, leveraging digital technology, leveraging research capacities that are available and the expertise that are available within the country. WHO India is committed to continue supporting Government of India and state governments in strengthening integrated, people-centered emergency care system. And most importantly, we will continue to work with the government in health promotion and prevention to prevent and control non-communicable diseases, including road traffic injuries and others. Thank you very much for your attention.
Thank you very much, ma'am. We have a token of love and appreciation for Ms. Payden, Acting Representative and Deputy Head, WHO India. To do the honors, I would like to welcome Honorable Minister for Health and Women and Child Development, Government of Kerala, Srimati Veena George. Ladies and gentlemen, let's have a huge round of applause for Ms. Payden. Thank you so much, ma'am. Also, we have a small token of love and appreciation for Srimati Tinku Biswal IAS, Principal Secretary, Health and Family Welfare. To do the honors, I would like to welcome Dr. Thomas Matthew, Director of Medical Education, Kerala. Ladies and gentlemen, let's have a huge round of applause for Srimati Tinku Biswal IAS, Principal Secretary, Health and Family Welfare. Thank you so much, ma'am. Moving on to the next person. I would like to welcome Dr. Mohanan Kundumal, Vice Chancellor, Kerala University of Health Sciences, to address the dais.
Good evening. Honorable Minister, Srimati Veena George, dignitaries on the dais, off the dais, eminent leaders of the emergency medicine profession, my dear students. I'm extremely happy and proud to stand before you, and I would like to congratulate all those who are behind organizing this first international conference on emergency medicine, and I think this is a historic one. And this actually celebrates the great decision by Government of India, Niti Aayog and NMC to have emergency medicine departments in 660 medical colleges of India. This is going to transform the medical education, transform the way we are going to see the emergency medicine, and transform the way we are going to see our patients, and thousands of our brothers will be saved. There is no doubt about it. But then, what is the most important thing? We have to have human resources, and that is the job of the universities. That is the job of people like us. And I assure you that we will see that every medical college in Kerala, all the 32 medical colleges will have a full-fledged emergency medicine department, and we will start postgraduate courses in all these departments. But then, doctors are important, but equally important are the technicians, equally important are the nurses, and we don't have robust courses for emergency medicine technicians and emergency medicine nurses. This is our duty, and within few months, Kerala University of Health Sciences is going to roll out emergency medicine technician courses, graduation courses. It will be done. It is going to be done. And similarly, emergency medicine nurses, definitely our nurses are world class. So now we are going to create world class emergency medicine nurses. So that again will be done. So now, more importantly, every doctor in the state is to be competent. So we have to have courses to empower our doctors. And I request all the faculty who have come here, please help us, so that we will roll out courses for the doctors who are practicing in the government hospitals, district hospitals, taluk hospitals, and therefore this state will be safe for any person who is in an emergency. That's our dream, and let us work together to make this dream achievable. I once again congratulate all those who are behind this. Thank you very much.
Thank you so much, sir. Next, I would like to welcome Mr. HSD Srinivas, Director, Healthcare Tata Trust, to address the dais.
Honorable Minister for Health and Family Welfare and Child Development, dignitaries on the dais, my learned colleagues in the audience, it gives me great privilege to put on record our sincere appreciation from Tata Trust for the kind of beautiful partnership that we have had with Government of Kerala, all the representatives who have tirelessly worked for the last 5 years to make a small part of this dream come true. Tata Trust is privileged to have partnered with people in the medical education department and health department, and made this advanced Apex Trauma and Emergency Learning Center a dream come true for us. As we all have been hearing since morning, this is the leader. Kerala, the state is a leader in innovating and bringing health to the common man. And we hope establishment of a center of excellence here will further augment the capabilities of not just the doctors and the frontline health workers, but also the community as a whole, and becomes a model for everyone to emulate. We thank Madam for this very patient, perseverant, and passionate PPP model here. Thank you so much.
Thank you so much, sir. Next, I would like to welcome Dr. Vishwanathan KV, HOD Emergency Medicine, GMC Trivandrum, State Trauma Nodal Officer for the thank you note.
Honorable Chief Minister, Honorable Minister for Health, Veena George Madam, Principal Secretary, Tingu Biswal Madam, host of other dignitaries on the dais, off the dais, international faculty, national faculty, my dear colleagues and friends. It's indeed a great pleasure for me to be here to render this vote of thanks, the first international summit ever and organized by the state of Kerala, taking the initiative to develop emergency medicine as a department and create world-class emergency medicine departments across the state. It's a big vision headed by our Honorable Chief Minister and a great passion by our Honorable Minister for Health that we have been able to achieve what we have achieved so far. It is a very small statement if I say that have you ever seen any minister sitting with the team 40 hours, spending over 22 meetings just for developing the emergency department? And it's none other than our Health Minister, Veena George Madam, and the initiative taken by Madam and the continuous efforts, I would say, to the extent that Madam will even call us and personally make us do things. So this is impossible, I would say, if Madam had not taken this initiative. People have learned to work and do what is supposed to be done. So the leadership is very important whenever we embark upon such major projects. The Quality Improvement Initiative is the brainchild of our Honorable Minister, and we have formed a core committee and a committee of members who would look into developing the emergency departments across the state. So we are in the process of doing this. My team members, Dr. Jayakumar is here, Dr. Ravindran is here, and I cannot name all of them because of the want of time. But however, all the members of the team, they have been doing excellent work, and we have to report to Madam directly on what has been achieved. With these few words, let me now enter into my solemn duty of saying vote of thanks for the Honorable Chief Minister, Pinarayi Vijayan sir, who has, in spite of all his personal and official commitments, made it possible to come here and address us. It shows the commitment of the government and the commitment of the team for creating what is seen today. And Parent Madam, we visited both the Atal Center and the Emergency Department, and we got the feedbacks from Madam, and I'm sure most of us here, even Dr. Venkat Narayan, Niti Ayog, we had visited all these facilities. Indeed, I am sure that whoever has visited our facilities are impressed, but it is still not time for us to say we have done it. We are continuously striving to achieve more and more. The excellent support given to us in creating the training center by Tata Trust, and also the support rendered for organizing this seminar is beyond words. I must thank Tata Trust for having given this opportunity to organize such a meeting. And year after year, I would suggest that KEMS 2023 continues to be live, and we are able to host it year after year. Support by National Health Mission, Government of Kerala, thanks to Tingu Biswal Madam, we have got excellent support from the NHM, Government of India. Kishan Kumar sir is here, and I must thank Manas and Kishan Kumar sir for having made this possible. The AIMS team has been a backbone of support to us. They have really helped us in developing the institution developing and also giving us guidelines and supporting us all through. Headed by Sanjeev Boy sir, Parveen Agarwal sir, we have had a great occasion to be part of the team to develop this commitment. Let me also thank all the international speakers, Tashi Thoge, Amit Gupta ji, Siddharth Dubashi, doctors, Dr. Sagar Golwankar, Dr. Lee, and host of other dignitaries. I am sorry if I have missed out anybody for having come here or online to have participated in this program. I would be missing in my commitment or my duties if I don't mention my organizing team, the Young Brigade, Dr. Anil Sundaram, and down to all my senior residents and junior residents who have worked relentlessly. I don't think they have slept in the last 1 week, carrying physically all the load of things, all the materials, and everything that is possible, and making this event a wonderful one. I must also thank the media, the event management team, Obay Tamara, and Atalk for having made this possible. Thank you so much. If I have missed out anybody, please excuse me, and it's only for the want of time. And thank you all once again. Thank you very much.
Thank you so much, everyone, for joining with us. And here we come to the end of official inaugural ceremony of Kerala Emergency Medicine Summit 2023. Definitely, all 3 days will make you guys to share your thoughts, perspectives, and knowledge with each other. And let's keep the legacy of health sector in Kerala keep flying high. Thank you so much, everyone.